Very good morning to all of you here. We are now moving on to day 2 of International Conference of Craniofacial Pathology and Biology. Due to technical glitches, we'll be shifting out the plenary session of day 2, and we will be moving to student and faculty presentations now to the decennial hall now. So we'll quickly start with the presentations here. The lecture from Leeds University is being shifted. We seek apologies for this unexpected delay and shift of schedule. Hope all of you will kindly accept this shortcoming. And after the student and faculty presentation is started, and after which the last plenary session will happen, and the Leeds University presentation will happen at a later time. Thank you so much for your kind understanding. Thank you.
Good morning, everybody. Thank you so much for your presence. Now we are going to start with a scientific paper presentation, the first session. So we have the first presenter. Before that, I extend a very warm welcome to Dr. Murli sir from RV College, Bangalore. Thank you so much for chairing the session, sir. So our first presenter for the day, Dr. M. Parashakti.
Good morning, everyone. Today, I'm going to present a topic, case series on heterogeneous presentation of oral squamous cell carcinoma. I am a research scholar from SR Dental College, Ramapuram. Moving on to introduction, oral cancer is, as we all know, is the 16th most common cancer, and it may arise in any intraoral site, such as buccal mucosa, labial mucosa, etc. According to Globocan 2022 statistics, it is the 16th most common cancer, and clinically it doesn't follow the same pattern all over the world. It may arise as redness of mucosa with pain or painless, as an ulcer, white deposits, etc. Etiology is not restricted to the use of tobacco alone. That means it involves alcohol with the tobacco. Patients who are using tobacco and alcohol have more risk of oral cancer. Other reasons are human papilloma virus infection, sharp opposing tooth. Now we move on to the case series. The aim of this is to review the mode of presentation of oral cancer along with novel therapeutic approach. This involves 15 different patients in both genders and different age groups with and without deleterious habits. The methods for this includes demographic details, tobacco history, and intraoral examination. First image shows a 47-year-old female patient who was a tobacco user, and all the other images show a male patient with tobacco use. The next slide shows a cancer on floor of the mouth and other intraoral sites. All of them were user of tobacco. All the 4 images of from male patients with tobacco use. Now, a typical case, leukoplakia turning into oral cancer within a short period. A 27-year-old male patient came with a complaint of some white patch in the buccal mucosa, but in a short time, initially it was mild dysplasia, histopathology report was given, but in a short term, it turned out to be a oral squamous cell carcinoma. He was also human papilloma virus positive. Histopathology report, the microscopic image shows some few clear cells. Next, the non-tobacco users, a 54-year-old female patient with sharp cusp with no habits. She was also diagnosed as cancer patient. Another patient, female patient, she was also diagnosed as cancer, but she had no habits. The findings are patients with the use of tobacco along with alcohol are more dangerous, and they came with stage 3 or 4 stage. Most of the patients were males with age group of 25 to 65. My research, I am being a research scholar, my topic is salivary microRNA 4863P in oral cancer. For initial stages, there was a lower fold change value compared with other grades, other stages, stage 3 and 4. So, altered microRNA expression is also playing a role in cancer. But these were in contrast with Chow et al., who did a study on same microRNA in Taiwan population on tissues. To conclude, tobacco use alone is not the only reason for oral cancer. Sharp cusp may also be a cause. Tobacco users with alcohol show severe symptoms. The reason being due to the acetaldehyde formation, which is a carcinogen. This prevents the DNA synthesis and repair of this. Heavy smokers are more prone for developing OCC 3 times more than normal or less use of smoking. Tobacco and alcohol show synergic effect. Floor of the mouth cancer have poor prognosis. So this case series emphasizes the importance of early diagnosis and periodic follow-up is necessary for patients. Advanced therapeutic approaches in and the recent advances are immunotherapy, targeted cancer stem cell therapy, photodynamic therapy, phytochemicals such as curcumin, sulforaphane, etc. CRISPR technology is also an emerging tool. These are my references. Thank you.
Thank you, Dr. Parashakti.
Thank you, sir.
Any questions from the audience? None? Any questions? Okay. You have a case series of 15 patients,
Yes,
right?
sir.
Everybody came at almost the same stage or at the different stages of them?
Different stages. Some with grade stage 1, some with stage 4 inoperable stage also, like floor of the mouth. They are very, very difficult to operate the lesion biopsy doings.
Okay. And as of now, what is the status of those patients?
Some of them are went for palliative care therapy, sir.
Okay.
Some did surgical procedure, excision biopsy, and they are under chemotherapy, sir. Some are with radiotherapy and routine chemotherapy drugs.
So out of 15, what is the your maximum survival rate you given to them? The surgeons have given to them. Out of 15,
Yes,
how
sir.
many had surgical procedures?
Sir, 5 of them had went surgery full lesion biopsy, excision biopsies, sir.
Okay. And how many of them have been really ill or they are recovering?
Sir, 10 of the patients are
Yeah.
went for adare cancer instead for palliative therapy and other treatment modalities, sir.
Okay.
Some of them are went for a stage very severe illness, sir.
Okay.
Like 2 patients are that only, sir.
Okay, fine. So no metastasis were there, like all of them are, you said different stages.
Yes, sir.
Could you find some metastasis in 2-3 patients at least?
Only one patient with a stage 4.
Stage
he,
4.
he had a metastasis, sir.
Okay, thank you, Dr. Parash.
Thank you,
Bye.
sir.
Thank you, Dr. Parashakti. Our next presenter, Dr. Deepa Palani Nandan.
This one, conference people family.
Good morning, respected judges. My presentation is on long wavelength OCT in diagnosis of oral soft tissue pathologies. There's a global burden, increasing global burden of oral diseases. According to WHO, 3.5 billion people are affected worldwide, and prevention and early detection of these diseases is the primary approach. Conventional diagnosis involves clinical examination and biopsy. Biopsy means invasiveness, and it reduces the patient's cooperative there's a time delay, and there's going to be an operator variability. So what we need is a real-time, non-invasive, advanced surveillance and screening tool for early lesion assessment. Optical coherence tomography is also known as optical biopsy. It's a non-invasive procedure, a real-time imaging, non-ionizing, and gives an increased resolution. So what is OCT? It's based on a low coherence, So optical coherence tomography is a non-invasive imaging that can be used inside the body with a fiber optic device and a harmless light source to provide morphological details as much as 0.5 micrometer resolution. It enables real-time tissue architecture visualization. So this will help us in identifying the region of interest when it comes to biopsy, reduces the sampling error, and helps in identifying tumor margins intraoperatively. The key parameters are resolution, imaging depth, loss of sensitivity with depth, and signal-to-noise ratio. The principle of OCT is based on low coherence interferometry. Light from a broadband source is split into two by a beam splitter, one towards the mirror, which is reflected back, and one towards the sample, where the back-scattered lights are collected, and both these reflected rays are combined and are detected by a photodetector. So it measures the backscattered light intensity and is analogous to ultrasound imaging. There are different types. The time domain OCT, which is historical. The Fourier domain OCT for increased speed. It can be spectrum-based, spectrometer-based OCT, or swept source OCT, where there are two different wavelength lights used. Angiography OCT is widely used in ophthalmology, and it is widely integrated clinically. This is why there is a growing research to implement it in dentistry. The clinical utility of OCT is to assess the pathology and to assess the surface interface. So dysplasia, malignancy, vesiculobullous lesions, periodontitis, and the surface intersurface assessment of in case of demineralization of enamel and dentine, early caries detection, cracks, assess margins of restoration, crowns, dentures, and implant interface, evaluate the enamel thickness and thickness of the biofilm. The predictive imaging features identified by the OCT is the epithelial thickening, the architectural disorganization, the basement membrane integrity, the epithelial connective tissue interface, and reflective patterns. So you can see the image here, the bright white line is actually the keratin layer. So you can see the epithelium and the connective tissue. The basement membrane cannot be well appreciated as we appreciate it in histopathology. The picture C shows a blood vessel. So you have two hyperreflective lines and a central hyporeflective line. The final image is of an ulcerated area in gingival epithelium, where you can see break in continuity of the hyperreflective light. This is what I have explained. So retipex can be seen. Retipex can be seen as shadows, and in case of hyperplasia, there will be a thicker layer, a thicker or a broader layer in the epithelium thickness. There is going to be a hyperreflective signal In frictional keratosis, in severe dysplasia and carcinoma in situ, it's going to be disorganized tissue. Hence, it's going to appear hyporeflective. In invasive carcinoma, the hyporeflective keratin layer or no keratin layer is seen due to ulceration. Why long wavelength OCT in oral soft tissue pathologies? That is because we need penetration depth of at least 1 millimeter. When they have done studies with 890 nanometers near infrared OCT, they could evaluate the dysplastic changes effectively. But however, lower wavelength, there's better resolution, but there's a decreased penetration depth. At 1300 nanometers, most of the researchers have used that. They found deeper penetration into the keratinized tissues. At 1500 nanometers, penetration of bone was seen, but at lower resolution. As the wavelength increases above 1300 nanometers, there was an issue because of the limited penetration in the thick soft tissues. Blood could absorb these long wavelength rays. To enable the appreciate the pre-malignant, early malignant changes, researchers have started using nanoparticle enhanced contrast. OCT versus histopathology. OCT cannot provide the cellular level details essential for identifying certain histopathological features such as nuclear atypia or early invasion. Hence, histopathology remains the gold standard. When they have compared the OCT and histopathology, the correlation was maximum with epithelial thickness, the architectural organization, reflective pattern, and lowest with the basement membrane disruption. The challenges are limited penetration depth by the infrared rays. So the imaging is restricted to the epithelium. Longer wavelengths above 1300 nanometers may be required, but this means there's an increased equipment cost and there's going to be less resolution. To visualize architectural changes can be done, but you cannot appreciate cellular changes. The dental lesions are wider in centimeters and hence multiple images need to be taken for larger lesions. Therefore, we need a wide field OCT. Variable histological structures and restorations are present in the oral cavity. That means the diffractive indexes and the thickness will alter the penetration, scattering, and absorption of light, which will alter the image formation and interpretation. Application in screening of suspicious lesions, biopsy site selection, margin assessment during surgery, monitoring lesion progression or response to therapy. Future directions are AI integration, use of wide field OCT, a portable handheld device, and integration into routine dental screening. To conclude, long wavelength OCT, particularly around 1300 nanometers, provides optimal penetration and interface contrast for non-invasive assessment of oral soft tissue pathologies. The patient is more compliant with dental procedures as biopsy after imaging, and the availability of portable handheld miniature optical device can make it a part of the routine dental screening in the future. These are my references, sir. Thank you.
Thank you, Doctor. Nice, interesting topic. Any questions? More. Can it, since it's long wavelength, is it possible for it to penetrate all the barriers of dentin, complete thickness of dentin? Can it penetrate?
Yes, sir. Yes, sir. Actually, we are well doing the review, sir. 590 to 600, that gives a better resolution. And because of the characteristics of the enamel, the prismatic substance, so it was we were able to get, like studies have said that you have better resolution when we use those wavelengths for enamel and dentin for the hard structures in the oral cavity.
Okay.
But for the penetration of the soft tissue, at least 1 mm is required, sir. So you get epithelium and the connective tissue. That is why we need to use the longer wavelengths.
Okay. See, basically I'm from conservative dentistry and endodontics.
Yes, sir.
Is it possible in the days to come that OCT can be used? You said real time, right?
Yes, sir.
Real time for just assessing the working length, is it possible? Is it anyway possible? Because it has to penetrate the bone and the cementum, and is it possible, or through the root canal is it possible?
Through the root canal we can do it, sir.
It is
Yes,
possible.
sir. Through the root canal, because the light will pass through the enamel also.
Okay. How do you think it can be done?
Sir, there is a separate optics for the hard tissues in dental, sir, for the enamel and dentine. So you have wavelengths which are shorter, 500 to 700, 800, sir. Within that wavelength, because it will give a better resolution, and it's passing because of the prismatic structure of the enamel. So it is possible in hard tissues, and it has given more positive results in the hard tissues for dentistry. It is in the soft tissues which is a little bit an issue.
Okay, anyway, it will be through the access cavity only. I don't think any impediment will be there for that to be showing the working length.
Yes, sir.
Any literature that you can work on that, it will be really
Okay,
good.
sir.
And you said it is definitely not as invasive. It is
Yes,
not
sir.
invasive at all,
Yes, sir.
right?
Yes, sir.
Okay. Thank you, ma'am. Thanks,
Thank you,
ma'am.
sir.
Bye.
Thank you, Dr. Deepa. Our next presenter, Dr. Radhika Sridharan.
And clone to cure. Control.
A very good morning to everyone, respected judge and all the participants. So my topic is on clone to cure therapeutic cloning derived organoids for oral tissue regeneration. So basically, saving a patient life in the field of oncology is not just enough. So we have to restore the structure as well as the function of the lost tissues. So the lost tissue can be in the form of tongue or the condyle or the jaw, or it can be a salivary gland. So restoring the structure and function of the lost tissues plays a vital role for the patient's survival after the post-cancer surgery. So my topic focuses on how we restore these lost structures through therapeutic cloning combined with organoids. So this therapeutic cloning actually not only restores the structure, but also it restores the function. So this therapeutic cloning offers patient-specific, immune-compatible tissue regeneration with significant potential for restoring the lost oral and maxillofacial tissues. So now let's see from the basics. So cloning is actually the production of genetically identical cells or copies of DNA. So this cloning can be of natural or artificial. So this therapeutic cloning comes under artificial. So in this therapeutic cloning, what happens is we take an adult cell and then we take the nucleus from the adult organism and then we transfer it to the oocyte, and the oocyte you have to remove the nucleus. That is an enucleated oocyte. We have to inject the somatic nucleus and then it will be cloned for therapeutic purpose. So for the normal cloning, we are not going to produce an entire organism. For this, we are just going to clone the cells and use it for the tissue repair purpose, so which will have a high pluripotential nature when compared to the induced pluripotent stem cells. These embryonic stem cells will have. So these embryonic stem cells can differentiate into any type of specialized tissues because these are embryonic stem cells. So they have potential uses in neurodegenerative diseases, Parkinson's, and dry age-related macular degeneration, and type 1 diabetes. So the same concept can be used for oral tissue regeneration. So the procedure actually involves, you take a somatic cell with the desired genes that is from the patient, you remove the nucleus alone, and egg cell which is enucleated, and then when it is injected into the somatic cell, so we produce the clone of cells, and that will have the nature of embryonic stem cells. So here it is, it will show these embryonic stem cells have the pluripotential nature, that is, they can differentiate into any type of cell. It can be a nerve, it can be a bone, or it can be a skin, because they are natural pluripotent stem cells when compared to induced pluripotent adult stem cells that we commonly use. So, why these stem cells are not alone enough? Because when these stem cells, they are just two-dimensional in the cell suspension, so they do not survive well. So these organoids are 3D, multicellular and self-organized structure. So they actually bridge the gap between the cells and the organs. So they actually mimic the specific organ that we are going to regenerate. It can be a salivary gland or it can be a muscular organ like tongue. So what are these organoids? So these organoids are 3D self-organizing mini tissues which are derived from embryonic stem cells, or it can be an induced pluripotent stem cells or adult tissue stem cells. So they actually replicate the native tissue architecture, the cellular structure, and the most important is they restore the functional behavior of the particular organ. So when these therapeutic cloning is combined with the derived organoids, so they actually help in transplantation. So it can be used in the case of post-cancer tissue loss. So we go for the hemimandibulectomy or maxillectomy, or we remove the hemiglossectomy. So the tissue loss is there. So post-cancer surgeries, it can be used, or it can be used in the case of radiation-induced tissue damage, or in case of any traumatic defects, or can be a congenital craniofacial anomalies, or it can be used in the case of TMJ arthritis, TMJ degeneration. And so the advantages are the immune rejection will be less because we are going to use the native tissue from the patient. So it is patient-specific regeneration, so we are not going to take it from other. So it restores the function. So, the first is the regeneration of the tongue. So there are some animal studies. So currently only animal studies are being done. So it has not gone to the preclinical stage. But the animal study have proven in a rat model where collagen gel carried myoblast progenitor cells are transplanted into a hemi-resected tongue in a rat. So that leads to muscle regeneration. And the most important is the reduced scar contracture. So this tongue degeneration is required because tongue is a muscular organ. So the contraction can happen. So it is needed for after the cancer resection, trauma, or congenital defects. So in animal studies, it has proved to be successful. So the next is regeneration of mandibular condyle. So this is quite complex because the condyle has bone, cartilage, and the growth zone. So these organoids, when they are combined with the therapeutic cloning embryonic stem cells, they actually mimic the condylar microarchitecture. So this stem cell derived organoids can form the structured tissue units, so they replace the function also. So in case of a rat model, a human-shaped mandibular condyle was successfully constructed from osteogenic and chondrogenic induced rat bone marrow stem cells in a biocompatible polymer. So this results may provide ultimate first evidence in stem cell-based engineering for degenerated condyles and associated with any kind of arthritis. So next important thing is salivary gland. So the salivary gland, the main function is production of saliva. So we have to restore the function, not only the structure. So this salivary gland regeneration is required in case of any radiation therapy or Sjogren syndrome and congenital defects or age-related dysfunction. So in studies in rat models have demonstrated two major regenerative approaches to restore it. One is using the stem cells in the organoids, and salivary gland organoids mimic the native gland structure, and because they enable the functional acinar and ductal tissue formation, and because we use the scaffolds. So next is alveolar bone regeneration. So here this has been, animal studies have been tried in rat, rabbit model and primate model. So in rat model, bone regeneration with the embryonic stem cells on a scaffold produced good results because functional alveolar bone tissue was grown. And in the rabbit model, 3D bioprinted bone with embryo combined with the embryonic stem cells have shown proven result. And in primate model, large-scale alveolar bone repair has shown a proven result. So it showed potential for clinical translation in humans due to similarity between the primate and the human bone healing. So we have seen so far the beneficial effects, but still we have some limitations because embryonic stem cells, it requires some ethical issues, but because we have to take the oocyte for using this, so it involves ethical issues and regulatory restrictions are there. So it is not easy to obtain the oocyte, but still because of the beneficial, because they have high pluripotential nature, they can differentiate into any type of cells that we cannot get it from induced stem cells. So still, if we overcome the ethical issues, it is good to use. And the one other disadvantages, it has tumor formation potential is more, so that we can overcome by using some caspase or gene editing techniques. And the organoids, they have limited vascularization and the lack of immune or vascular integration. So these are some of the limitations. So thus I conclude by saying that science of today is the technology of tomorrow. So this quote actually reflects how the transformative potential of the embryonic stem cells in the regenerative dentistry. So this therapeutic cloning, when combined with the organoid technology, it represents a shift in the regenerative dentistry because we are creating a patient-specific immune compatible organoids that will closely mimic the oral tissues that we are going to replace. So which is very beneficial for the patients because after post-cancer surgeries, the rehabilitation is more important because they have to survive. So it is quite important. So these are the references. Thank you.
So the cells have to be, you said somatic cells, right? So it had to be native of that region or not necessarily?
No, sir, not necessary. Any somatic cell, it can be taken and from the patient. For which patient we are going to treat, from the patient we have to take it, sir.
Why will the ethical issue come then?
So we have to use the oocyte, sir. The oocyte. So in the oocyte, because we are taking the nucleus alone from the somatic cell, and for the cell, for the cytoplasm, we are taking the oocyte, and the oocyte we are removing the nucleus and then combining it.
Okay.
So since it leads to embryo destruction, so it will have ethical issues, but we are not going to go for the artificial cloning, that reproductive cloning. So it is just for tissue repair. So.
If at all any cells of your easiest is available from the wisdom tooth, is it possible? Or
Yes,
any DPSC, is it possible to use for this?
Yes, sir. Yes, sir. Any somatic cells can be used. But the only thing is we have to get an oocyte to combine with it. Because the cells that we take from the wisdom tooth or pulpal, we are going to induce it using the growth factor. But here we are going to use it the natural pluripotential nature because we are going to use the embryo.
Thank you, ma'am. Nice introduction.
Thank you, Dr. Radhika. Next we have Dr. Kundana Durga.
Yeah, Google search.
Good morning, everybody. The topic of my presentation is computational screening of Desmodium gangeticum derived compounds for the therapeutic potential in oral carcinogenesis. Before I move on to my presentation, I want to break down the title of my presentation. Computational screening is nothing but an in silico evaluation of the compounds of a plant named Desmodium gangeticum, which is native to Ganges, that is near Varanasi or in the Ganga. And the compounds that we have derived are phytocompounds, and we want to check the medicinal properties of that compound against oral carcinogens. So these are the contents of my presentation. Coming to the introduction, as we all know, oral cancer is often linked to habits like tobacco, and it is mainly due to the chronic inflammation that is produced by these habits, which cause chronic inflammation, which in turn promotes oral cancer by inducing DNA damage, cell proliferation, and neoangiogenesis. And now talking about my plant, Desmodium gangeticum is a traditional Ayurvedic plant which is commonly available everywhere. It's also called as Shalparni, and it is used in many Ayurvedic formulations. And it exhibits potent anti-inflammatory activity primarily through the inhibition of pro-inflammatory cytokines like interleukin-6, TNF-alpha, COX-2, and MIF pathway, that is macrophage inhibition pathway. And we extracted few bioactive components from this plant, and we just wanted to see if they can target cancer-related pathways. The computational screening that I've done here helps in identifying the potential drug candidates that can be used against oral cancer cell lines. So my study was completely focusing on identifying this plant and this plant-based components if they can inhibit oral cancer progression. So coming to the methodology, these are all the products, or these are all the platforms that I've used for my computational docking. So coming to the first thing, that is BioVia. It is basically an app wherein you can extract all the components from the internet or available sources, and you can visualize a 3D model of the component. And PubChem is the source or the website where I've checked for all the components. Swiss target prediction is something where you can just enter your plant and you can get all the possible combinations or phytochemicals or active ingredients in your plant. And SwissDoc is the most important of them all. The things that we downloaded from BioVia, we are going to make all the components interact through SwissDoc. We'll know how much our component is binding to the receptor. So this is the flow chart of my entire methodology. So first we selected the compound, and we retrieved all the phytochemicals of my plant from PubChem, and we prepared ligands or 3D structures through BioVia Discovery Studio, and the target protein was selected from PDB or the protein data bank, and then we prepared the protein same in BioVia by removing water molecules and by adding hydrogen atoms, and we did the docking through SwissDoc. So this is the receptor that you can see. The supercoiled structures that you can see around is the receptor, and the one that is binding in between, which has hexagonal shape, is the ligand or the target drug that I've used. So these are the individual components that out of probably 50 or 55 components, I selected 7. So the first one that you see, artemisinin, is already being used in routine oral cancer therapies in chemotherapy. So all the other things, desmodin, gangetin, camphorol, formonetin, and quercetin, these are all the components of my plant. And here you can see varying spheres, that these are of different colors in this. You can see the red colored bonds also. So I'm going to talk about the individual components in this. The green color spheres that you are seeing are basically the hydrogen, or these are the hydrogen accepting donors. So these regions will accept donors from the receptor for better binding. The yellow color spheres are hydrophobic areas where the ligands usually don't bind. The purple colored ones are the bulk of the component that we have used, basically pi-pi interactions and the aromatic components of the entire component or entire compound is the purple colored one, and the red colored lines that you can see are the hydrogen acceptors. So after that we saw the binding energy of various components. The control drug that I've used is artemisinin, and it had a binding energy of about 7.5. All other components had a varying percentage of binding energy, but the one that was very critical for us was gangetin and desmodin. Both of them had a greater binding energy than the original compound. So the basic idea behind showing up a binding energy or something is that binding energy is essentially binding of the receptor to the target drug. So if I'm getting a control of 7.5, if I'm getting components which are greater than 7.5, it essentially means that my compound is binding well to the receptor, and this can be a potential area where I can use it in oral cancer. So these are the individual components, these are the ADME properties, and these are all the compounds that I've used. We can see that the control drug marked in blue has 4 hydrogen acceptors, 4 hydrophobic groups, and all others have varying things. So the one that is very near to the original drug are camphorol and quercetin. And this is biocompatibility. Here we can see that the control drug has no violations, and although even all the phytocomponents have no violations except for gangetin. These are the ADME properties and binding energy as a whole. The bioavailability of this component is around 0.55, and all of my phytocomponents also had a bioavailability of 0.55. So here we just have to look on to the molecular weight. Artemisinin is around 262, and we have quercetin around 302, camphorol around 286. But we have seen that gangetin and desmodin have greater binding energy, so we are moving on to that. Coming to the discussion, this plant that I've spoken about is rich in flavonoids and alkaloids. It has anti-inflammatory properties, antioxidant properties, and through this molecular docking we also found out that it has anti-cancer activity also. The target protein, that is macrophage migratory inhibition factor, is predominantly involved in chronic inflammation, and it helps the cells to evade immunity, and it also causes progression of the oral cancer. So desmodin, out of all the components that we've seen, desmodin showed the highest binding affinity of around 8.27, which has strong interactions with MIF, and this actually means that it has inhibitory and therapeutic effect. The control drug, artemisinin, is a known anti-inflammatory agent, but it showed a lower binding affinity than desmodin and gangetin. So there's also something peculiar about this. The more the number of hydrogen bond acceptors, the better will be the binding of the drug to the receptor. So desmodin and quercetin here showed more hydrogen bond acceptors, so there is better binding stability. And following the drug likeliness profile, we saw that all the compounds passed all Lipinski, Weber, Gose, and Egan rules, and there was one violation, which was also within acceptable limits. There was uniform bioavailability across all the components, and the log P was also within the ideal range. So the bottom line or the conclusion of my study was that desmodin gangeticum shows promising MIF targeted anti-cancer potential through its bioactive flavonoids with strong binding affinity and variable pharmacokinetics. Thank you. These are my references. Thank you. Sir, for anything, like usually the drug characterization we do, we take the components out of the plant and then we start doing it. Like we use our own resources like the cell lines in vitro and we do it, sir. So this is like a preliminary step. Before doing it before wasting our resources or anything, we just selected a plant, sir. We have seen that there is enough literature supporting that it can work as a potential inhibitor for oral cancer. So we just took all the active components of the plant and we ran a simulation kind of thing, sir. So will it work? There's already lots of data available in this particular Swiss ADME, Swiss docking, sir. So this will give us an approximate idea if our phytocomponents are going to work or not. So it's like a preliminary before getting into the actual thing. This is just the groundwork that I've laid for using these components in potential therapies forward, sir. Sir, Sir, the outcome would be basically like I cannot use the individual component alone, sir, because as it is a plant, we'll only get combination of all the components, sir. So I just wanted to see, usually oral cancer prevention can be through many things, sir. But for my drug, I wanted to see if it is reducing chronic inflammation or it has any anti-inflammatory activities, especially in the oral cavity.
Thank you, Dr. Kundana. Next, we have Dr. Uma Maheshwari, HOD, Oral Medicine and Radiology, Saveetha Dental College.
Chairperson and respected delegates. So this presentation is a compilation of my 23 years of research experience in a particular field in forensic odontology, cheloscopy. Cheloscopy is study of lip prints. Just like fingerprints, which has been used as a personal identification tool, as an oral medicine specialist, I had taken lip print as a personal identification tool, and I am working on from my PG thesis. So this presentation is just sharing my research journey on cheloscopy. So for people who are not aware, like what are lip prints, before going into cheloscopy, basic understanding of forensic odontology is essential, because forensic odontology is exclusively a branch of medicine, which is actually, it's a branch of dentistry in which the interest of justice deals with the proper handling and examination of dental evidence with a proper evaluation and presentation of dental findings. You may be a prosthodontist or an orthodontist or even an oral medicine specialist, even an oral pathologist. Every information which you collect from the patient will serve as a potential ante-mortem record if it is properly documented. Maybe all cases may not require those evidence, but there may be an emergency like a natural mass disaster or a man-made disaster or any criminal investigation cases. These evidences can definitely will be helpful to compare with the available evidence to identify the suspect in case of criminal cases, again to identify any missing individual in case of personal identification. So all what you are recording as a cast being taken for prosthetic purpose, any photographs of the patient, the patient profile photographs which you register in the database, the radiographs which we take for many endodontic procedures, the sequential radiographs which we take for the patients, the teeth samples, bite registrations, Ruge markings and lip markings are all potential ante-mortem record. So in this I had chosen one particular anatomical landmark, which is a permanent anatomical landmark, lip prints. Lip prints are called or defined as normal lines and fissures in the form of wrinkles and grooves which are present in the transition zone of lip, that is between the inner labial mucosa and outer skin of the lip. And these wrinkles and grooves were called as sulci labiorum and as sulci labiorum and sulci fulcorum, which is actually a Greek and Latin word which represents lip prints. So cheloscopy has started in 1902 by the Fisher anthropologist, who only considered these as just markings for aesthetic purpose. 1932, Edmund Lockhart, a criminologist, found that these lip markings are identical, and like they may be identical or they may be unique. So let's investigate whether it can be used for criminal investigation. Cinder devised a classification, a very simple classification to define these lip prints. But the classification given by 1974 by Yashu Shushikashi is still considered as a standard classification of cheloscopy. So in 1970s and 1990s, people were only concentrating on classifying the typing of lip prints, classification and typing of lip prints. And before 2010, they were concentrating on personal identification and criminalization. Now I'm heading towards lip print biometric, which is my dream topic project, for which what are I have contributed from the time I had taken it as my PG thesis till date, what are the different research which I had done in kiloscopy will be the compilation of this presentation. And why at all we should concentrate on lip print? It's always there is a controversy. When compared to fingerprint, whether lip print can be used in criminal investigation cases, there are cases which have been reported earlier also in Poland and in other places in burglary case, where they have also found that lip prints can be traced from the glass doors, the windows, even the edible items like cake, apple core. All these have been recorded and documented in previous case reports, and definitely it can be applied in criminal investigations. Only thing is proper research work in kiloscopy is lacking. So this is the reason behind my journey, which began in 2003 as a PG student, where I collected 750 individuals, including male and female in the age group of 10 to 60 years. The uniqueness in my research was that lip print was traced in only 4 quadrants. I was the first person who started tracing the lip print in compartment wise, like dividing each quadrant into 3, and lip print was taken in each of the compartment of both upper and lower lip. And the classification given by Yashu Shushikashi in the year 1974 has only classified lip prints as type 1 to type 5. The presence of maximum number of lip print in each of the compartment was considered as the type of lip print belonging to that individual. Type 1 and 1 dash was given by Yashu Shushikashi. As you could appreciate, vertical grooves running across the lip, like from upper portion to lower portion, vertical grooves which is running across the upper to lower portion of lip is considered as type 1, and some may not complete the entire course. They may be in midway only. So they are considered as 1 dash. And type 2 are lip prints which has a fork in their course. Type 3 is when these forks intersect each other, and type 4 is like fence-like pattern. You have horizontal and vertical grooves giving a fence-like pattern. Anything which does not belong to these type is considered as type 5. This was a classification given by Yashu Shushikashi in the year 1974. In our research journey, we found that there were type 1 and type 1 dash lip prints. Type 2 lip prints were also appreciated, like grooves, vertical grooves which fork. But our unique observations was that, which we conducted in our Department of Oral Medicine, there were grooves which fork upward, there were grooves which fork downward, and there were grooves which had upward and downward fork. This subdivision was not appreciated in Yashu Shushikashi's classification. Type 3, as given by Yashu Shushikashi's classification, we found that the grooves intersect. Type 4 also, the reticulate or the fence-like pattern was well appreciated. Anything which doesn't belong to the category 1 to 4 was categorized as type 5. Again, unique observations recorded in our research journey. We found that there was circular area with minute dots which we classified as type 5A. And there were like leaf-like pattern, which you cannot put it under 3 or 4. So this will come under 5. But as a subdivision for 5, we classified it as type 5B when it gives a leaf-like pattern. And when you don't have horizontal and vertical grooves, we cannot classify it as 4. So we had classified this particular pattern as type 5C. And in our research journey with 750 individuals which we started initially, there were evidence that type 2 was predominant and type 4 was less prevalent. And the lip print study was conducted in twins, and it was also conducted in triplets also. And we also found that whether using the fingerprint experts, we were trying to use the same fingerprint methodology tracing for lip print. and we successfully traced lip prints in drinking glass, and we were able to compare it with the available lip print traced with tracing paper, and we could see that it was matching, and definitely lip print can aid in criminal investigation. And since as a PG student, I found that there were type 2 and type 5 lip print subdivisions which was not concentrated in the previous classification. So this made my research journey to continue after my post-graduation. When I became a PG guide, I started giving this as subtopics to my own students. And these were all the observations made by my student, and we had also published the results of these subdivisions of type 2 and type 5 lip print, and we found that in subdivisions of type 2 and type 5, the prevalent type was the subdivision 1. And other varieties were less prevalent, but they were present in the individuals, and it should be considered in the classification. And then my research started moving on from 2D to 3D transformation, because if at all we want to concentrate lip print in criminal investigation, we need to do a more detailed analysis of lip print, because only small traces of lip will be available in criminal case investigations. So in that particular small sample, how far we can identify the uniqueness of lip print, that's why we started doing a confocal microscopic analysis, where we do sections not only in 3 volume, but we even went to Z sections, and where we can see the typing of lip print even more clearly. So if at all we have a digital ante-mortem record and we have to compare it with the suspect, we can do a confocal microscopic analysis, where we can further analyze one particular sample, one particular compartment itself. We can do a detailed analysis so that matching of lip print can be done. And then I started understanding that though all this is in the research stage, translation to practice is missing. So considering this, I started preparing a QR coding system, where I first traced the lip prints using tracing paper or cellophane paper, and noting only the demographic details. The most important detail is just the age and the gender. And a lip print typing was done in all 12 compartments. So you get a 12-digit number, like how you get a 10-digit number for your mobile number. And this I started doing a QR code, so that this can be used as just a step to find out whether we can start digitalization of these anatomical landmark, so that digitalization of ante-mortem record can be initiated in institution level or in your private clinic practice, which can help the criminal investigators in future to restore justice. And this idea was also being patented by me, QR coding of lip print, which was first of its kind. And there were a lot of research where they had, apart from utilizing this lip print as a personal identification marker, they had also started identifying whether it can be correlated with oral and maxillofacial pathologies. To my doubt, I had a feeling whether this is true. So let me do a research on my own to find out any correlation. And I found that when I did correlation with dental caries, angle class 1, and with fingerprint also, I can boldly say that though there are studies which are saying that correlation of fingerprint, lip print with dental diseases is positive, but I found no correlation. And I found that we should not waste our research journey in correlation studies and only concentrate on personal identification and criminal investigation tool, and no more considering lip print as a genetic marker or should be used for correlation. So my future started heading towards incorporating AI technology, so that whether just like fingerprint biometric, can we achieve lip print biometric. So before going on to the research, I wanted to see the available algorithm available in artificial intelligence, whether it is feasible, whether it is again having a significant result. So I did a systematic review, and I found whether beginning with my question, whether lip print and artificial intelligence can be integrated. Will there be any networks available which I can utilize those networks for my future research? And I included all studies which have been, which the authors have tried using different artificial intelligence algorithm in studying lip prints. And I got studies also. And finally, around 8 studies I had included in my systematic review to find out the most appropriate neural network to continue my research on AI in kiloscopy. And I found that there were few algorithms like VG6, as you could see, VG6, VGG19 actually it was, the algorithm which was considered as most sensitive in the out of the 8 studies that was most commonly used and most sensitive study. And I also found that there were high risk bias studies also in the systematic review. So I cannot include the conclusion of all studies for my current research on AI in kiloscopy. So I concentrated on the low risk bias studies, those 2 studies, and the network used in those 2 studies. I started working on that. And finally, I started a preliminary a pilot study where I collected around 250 images. And in that 250 images itself, since we are not going to do each image as such in algorithm, we are trying to incorporate as many as possible images of type 1 to type 5. So to make that neural network to identify the type 1 to type 5. And this was just a preliminary study using these 2 algorithm, Navy, Bayes and logistic regression. And we found to a certain extent, artificial intelligence neural network can be used in categorizing, in identifying type 1 to type 5, in segregating or distinctly you can classify from type 1 to type 5 lip print. This just a small study to assess whether we can integrate AI with kiloscopy. And comparing the 2 algorithms available, we found that the sensitivity and specificity was almost matching both the algorithm, though there was slightly higher in the second one. The logistic regression was slightly higher, but still almost the 2 algorithm was closely matching with each other with not much significant statistical difference in the sensitivity and specificity. So these are my research. This is all my different part of research which I have done in kiloscopy. And with this, I also was able to generate many manuscripts published in both Scopus and Web of Science Index journals. And this, I am now heading towards the preparing this lip print as just like fingerprint, establishing the significance of lip print as a biometric tool. So I conclude my session thanking my mentor, Dr. Gnanasundaram, who had chosen lip print as my identity, a person who gave this as my PG thesis, and this made me to continue my research for my upcoming students. I thank my department, who has always been the backbone, my Saveetha University, which has, since I'm here for more than 20 years, I am able to utilize this research-enriched platform to continue my research in one particular thrust area. And thank you to the organizing team for giving me the chance to share my research journey. Thank you.
Thank you, ma'am. It was just one question. Does it vary in health and disease? By chance, if your lip prints, do they vary, show variations in health and disease? In that case, it would be difficult for him.
Sir, if you're asking me about correlation of lip print with dental diseases, no. But if we are having any, like herpes infection, we cannot collect lip print.
Yes, exactly.
We have to exclude those cases. But once the lesion heals, we can collect. Cleft lip, cleft palate cases, we cannot collect.
Okay. Does the pattern come back to the original form after the healing of any lesion?
We had done a study this also, sir, where we had almost traced lip prints for known individuals. We had traced for about 10 years period, and we found it was same. And then only we concluded that it is a permanent anatomical mark. That is also one of my study.
Thank you, ma'am. Thanks.
Thank you so much.
I request sir to hand over the participation certificate to me. With this, we go for a short break. So after that, the plenary session will happen. Then the technical sessions will continue. Thank you.
Good morning, everyone. So, we are now successfully moving on to the last plenary session of the International Conference of Craniofacial Pathology and Biology. We have a very interesting topic for the concluding session of the plenary session for this conference. It is something which is of critical importance, I would say, and the most important and very frequently used word, innovation. So this is something which the government is also heavily promoting, and it's the right time that we have invited an expert in this area to talk about how to do innovation, and design thinking again is like a key word now. We have with us expert Mr. Raghavan Sridhar. So Mr. Raghavan Sridhar is an electronics engineer by qualification. He is a he's been having a very successful tenure as a product development leader by profession. He has done his post-graduation in senior leadership from XLRI Jamshedpur. He has worked in Ericsson India Private Limited and was also the senior manager related to research and development. He is a widely acclaimed public speaker and is a corporate trainer. He has conducted more than 250 workshops on a plethora of topics for corporate and student across India. He has also achieved a lot of international acclaim, and he has also won a very important recognition in the internationally recognized Toastmasters group, where he is an international speech champion. And he's also been a design thinking practitioner. He has trained more than 1,000 students and corporates since 2020. He is also an Impact Award winner from Ericsson in the year 2021, and the highest individual award, which is the highest individual award at Ericsson, awarded only to top 2% workforce globally, and that is something, a phenomenal achievement, sir. We are very happy to have a person of such a caliber to be with us today. He is again also classified as Distinguished Toastmaster, the highest award given by Toastmasters to those who achieve unmatched excellence. Again, Toastmasters is a very, very stringent organization which trains individuals to become excellent orators, and topping in that isn't an easy job. And that is again a very big feather on your cap, sir. Thank you so much for accepting to be with us in this wonderful occasion. And this is a hybrid conference. We have online participants watching you as well. Over to Mr. Raghavan Sridhar, and I invite Professor Dr. Abhilasha to please chair the session.
Thank you so much, ma'am. Good morning, Saveetha. Do we have students from outside SDC also here? Yes, sir. Okay. The ma'am did warn me the engagement will be low, but I didn't expect you to answer when I asked them the question. But yeah, thank you for the introduction. It's always nice to hear nice things said about you. I will take that mic, sir, the collarless. Yeah, okay, good. Yeah. Does this work already? Okay, great. So, good morning, Saveetha. Good morning, everyone who has come to Saveetha. We can say good morning a little loudly, no? So, for any of you who are expecting a very serious session where there will be a lot of learnings and takeaway that you can go home and really recall and enjoy, the door is that way. Because we are going to play games for the next half an hour. We're going to sort of take your mind off pathology, chronology, biology, dentistry, tooth. Let's go a little bit into the heart and minds of people, okay? I hope you really want that. Or do you still want me to open my mouth and show you what germs I have inside? I hope not, yeah. All the introductions, I did do all of them. It looks more glamorous when you hear of it from the outside. More like your dentist career, right? When people call you doctor, for us, wow, doctors. But then I've been sitting right amongst a few of you, and all I can see are homeworks and assignments being done, calls being made to your friends. Ayyo, Kartalendi, gear kenda, 360-degree outfit. Does it come with dupatta? All those discussions. That's life, really. That life is what we are serving as dentists and doctors, yeah? And so we are going to talk a little bit about design. How many of you know what design thinking is? Doctors right there in your costumes, look up, okay? The more attractive, entertaining person in this room is me, not your Instagram reel, okay? So look at me, just tell me, how many of you know what design thinking is? Anybody knows what design thinking is? Nobody knows what design thinking is? Okay, I'll give you one punchline. Try to remember it, okay? How many of you like Ajit Vijay movies? The last person I expected to answer was you, ma'am, but still good. Yeah, how many of you like Ajit Vijay or Rajnikant movies? All those punchlines, right? Yeah, Rajnikant rendu kai. I'll tell you what design thinking is in a very understandable punchline statement, okay? It is not about what you can do. It is always about what the customer wants. Okay? It's not about what you can do. It's always about what the customer wants. Okay? Now, because I'm in the midst of doctors, I will bring up a few things that some of you might be familiar with. And I want you to tell me what is the use case behind all of this, okay? It's not the teeth, okay? It's that mirror, yeah? What do you call that, ma'am? Mouth mirror, okay. See, I didn't even know that, okay? Yeah. By the way, any non-dentists, non-doctors, any general audience in the house? Only me, no? And you too, yeah. Because I showed the poster to my wife yesterday. She asked me to read the title. It took me half an hour to read it without any mistakes, okay? International Conference for Craniofacial Pathology and Biology. Yes. My wife will be proud of. And yesterday I was watching the live stream, right? And at the end, I think it was ma'am, and she actually made it easy, and she said, "Thanks for coming to ICCPB." So like, if that can be done, why didn't you do that earlier? But yeah, so I didn't know the name of this. It's mouth mirror. Why was this created, invented, discovered? What purpose does it serve? Oh, you are sorry, ma'am? Fancy. Okay, any other answer? Indirect vision, okay. What else? Exact. Wow. You are talking to a guy who has no idea. Huh? Yeah, okay. Indirect vision, okay. Retraction, okay. What else? Oh, retraction, they said. Oh, okay, retraction, okay. Illumination, okay. The only Illuminati I know is the song. Okay, good. I am hoping this is the deal breaker for most of you. To set up a clinic, how much does it cost, huh? For dentists? Yeah, right, that's minimum 5 lakhs, huh? So what use case? Ma'am is very specific, sir, GST extra. How much did it cost you? You don't know? Yeah, fine, I understand. It's an expensive stuff, right? And some of you there, you might want to set it up in the future. No? Yes? No? Yeah? Okay. What use case does this entire setup serve? Huh? Loudly. Hey, I know some of you presented outstanding papers here. OCT, yes, I love the concept, but I don't even recall the terminology. From plants, how do you create medicines? When you can say all that, you can say, what use does this serve? Tell me. Somebody is actually giving me what I want. I will come to you soon, ma'am, okay? I will come to you. You are the only person who speaks English or Tamil that I understand. Okay, but yeah, okay, or let's go this. This one, yeah? Taken the market by a, at least for people like me who watch ads, taken the market by a storm, the Invisalign braces. What use case does that serve? Of course, Raghavan, either solradhukka neenga. Yeah, sure, align what? Sure, then there are braces. People have been known to wear braces from time immemorial. So what use case are you serving here? Yeah. Really? Are braces comfortable? Who wears braces here? I saw a couple of you. Anybody with braces in the house? Yeah, is it a comfortable experience, braces generally? Sir, dentist kitta vandu indha keliyala kettingina. Okay, yeah, I will tell you the original use case behind all of this, okay? I will slightly later. I'll tell you all one story now, okay? Can we listen to a story? A story you might all be a little more familiar with, but I'll tell you a story. And if in the next 5 minutes you are really interested, try and come down to these rows in between. Yeah, don't leave empty chairs. That will tell me you are engaged with me as well. Okay. Now, this is a story. This is a real story. Okay. I will tweak the names a little bit, but real story nonetheless. And listen to me with rapt attention, okay? Especially the women in the back in white and the men in the front with the blue. Listen to me fully, okay? With rapt attention, because I'm going to ask you some questions, okay? Good. Now there is a town in Rajasthan called Bikaner, okay? Name changed, but there is a town in Rajasthan called Bikaner, okay? It is a very hot desert, right? And in Bikaner, there is a small village, a village with about 40, 50 families. Now, when our Prime Minister's government took over in 2014, they did what is called Happiness Index Survey. And so they did a happiness index across the country in many different places, in Chennai also, but Chennai being a big sample space, I'm guessing none of you got interviewed in that sense. But in Bikaner, only 50 people, so they were interviewed. And then feedback came that the women of Bikaner were extremely depressed. Yeah, they were really, really depressed. Many of them have suicidal tendencies. Yeah, it's a very depressing place. So the government engaged with some design thinking practitioners and told them, hey guys, just find out what is wrong, fix it. You have good budget, not a problem. In compared to the size of the town, unlimited budget, so just go in, okay? And so a few of us went. Imagine you are also in that party, okay? We went, we put up a tent just inside Bikaner at the edge, I mean at the borderline, and then we observed them for 3 full days. This is what happens to the women of Bikaner, okay? What's your name, ma'am? Abhilash. I'm hoping this is your story as well. Where do you stay, Abhilash? Harrington, that's quite far, no? So you drive. You take your car, what time? Little earlier than 7. 7. I'm hoping you cook at home. Okay. No, English reaction. She doesn't cook, huh? Okay, fine. Okay, but I'm assuming this is a story of many of you, but let's listen to the women of Rajasthan. Hear them, okay? Their day starts at 4 a.m. in the morning. They wake up at 3:34. They go out just outside their door, and then there are places to clean. They clean the entire front porch. This one? Okay. Orange nalla irundhathu vathiyara. But okay. They clean the porch, and then they have cat. Sir, they are asking for the mic back here. Okay, he didn't hear. Okay. They clean the porch in the front, and then they have cattle, all of them. Yeah. Sheep, cow, goats, whatever they can afford. So they go to the cattle, they attend to them, feed them, collect their dung, come back, put it into water, and then clean the front porch again, make rangoli and all that. And then by 5:30 a.m., then they go start cooking. They start cooking, right? And then they have to keep cooking, and then about 6:30 they have to wake up the kids, wake up their husbands, feed the kids, make them get dressed up, get them ready for school, ensure homeworks are properly done, pack snacks for them, pack water bottles for them, then send them to school. And then once the younger kids are off to school, the older kids, the husbands, have to be attended to. Feed them, get them ready, make their dresses ready for them, get them milk, food, everything, get them ready for office, and then send them out. And then 9:30-ish, they start to eat for themselves. A little light breakfast, and then they go back to the cattle, attend to it, clean up the entire house, wash the vessels, put everything in order, clean the house, mop, sweep, everything. But about 11:30, they collect all the old clothes, collect all the empty pans of, empty pots, and then starts perhaps the most physically demanding aspect of their day. Bikaner, right? It's right in the middle of a desert. Not much in terms of a water source near them. So the entire women folk of the village take all the pots and pans they have on their heads. They don't even have shoes to wear because it's such an acrid place. It's very hot. Your rubber soles melt. And any vehicles you have, the tires sort of stick to the ground. And the roads are not very well laid, so it's very rocky. So 12 o'clock, all the women gather around. And then they take these empty pots and walk 7 kilometers away to a big pond with fresh water. And then they go there, they bathe, they wash clothes, and then they fill up the waters, and then they have to wait until the clothes dry, then get them, pack them, everything, make sure they are not in touch with the water so that they don't get wet, carry all of it on their heads, and walk back again 7 kilometers. Imagine doing this between 12 and 3 p.m. in the afternoon in Rajasthan. They walk back, they come home. Once again, a quick check on the cattle, quick check on everything is ready in home or not. And then around 4 o'clock, the kids come back. Get the kids ready, clean them up, ask them to do their homework, feed them some snack, send them out to play. 5:30, the husbands come back, wash their vessels, make them feel comfortable, do some household work. 6:30, dinner prep starts. They make dinner, feed the kids first, send them to sleep, feed the husband, send them to sleep, eat a little bit, tend to the cattle again, wash everything, put everything back, and then go sleep 11 o'clock. Next day starts at 4. And here we are saying, Saveetha Dental, we are having a very busy life. So, we watched it for 2 days, and third day I was depressed. How will you fix this, Abhilasha? How will you fix this issue? What will you do? Give me some answers. Yes, ma'am? Get water, how? Sure. But get water is a very broad statement. Yeah. Get water, how? What do you mean by get water?
Pipes laid.
Yeah, pipes, right? Lay some pipes, make sure water reaches you. Yeah, thank you, ma'am. What else? Yeah, stay near the pond. Where do you stay, my friend? In Chennai? You're from? Mumbai. Oh, okay. You're here on a visit? This is a romance between me and them. There is a reason why they put a chair for you here. Be a spectator. No, I'm kidding, but thank you. Are you related by any chance? Do you know if she cooks at home? Or? No. Oh, she doesn't cook. Oh, you don't know. Yeah, but you live in Mumbai. Where in Mumbai? Where did you study? Which is how much of a commute? Why didn't you move closer to your school? Die. Where? Thane? Just beside the college. Tell me a use case where you stayed far so that I can ask you, why didn't you move closer? No, but the moral of the story is it's not as easy as you think to relocate. How many of you commute far to college or wherever? Why don't you move closer? That's not a use case, yeah? It is a use case that might solve your problem, but add more to someone else. I'm guessing you're not married. Macha, once you get married, no. You can't even relocate from bedroom to hall. You have to wait. Your son is eating. The next door dog is barking. The opposite TV is playing a nice song, so you can't disturb. Yesterday cricket match, Surya Kumar Yadav started playing well. I increased the sound, my wife is like, shut up. That song is nice. So, okay. So what else can we do? Relocate, bring pipelines. What else? Sorry, ma'am? Brilliant. Transport, someone was saying lorry. Okay, yeah, good idea, good option. Arrange a lorry or a transport for water or for them? For water to reach you. Okay, brilliant. What else? I can hear you. Ha. I am very sure, Macha from Mumbai, this was an answer from a woman. Yeah, clap. Oh, you want to clap? Okay, Suganya ma'am wants to clap. Yeah, why should the boys have all the fun? Going to office and doing nothing there. You bring water. Yeah, good. I mean, very practically workable answer. Make the men do the hard lifting. Sure, great. Boys in blue, future waits you. Dentist. Okay, next. What else? What else? One or two more answers. I'm sure you can do well. The women in white. What would you do? Tanker, yeah, may arrange for water tanks. That's how Chennai is living on. Yeah, sure. One more answer, please. Abhilasha ma'am, you are allowed to answer. Sorry, sir? Yeah. You have to tell me. We don't know what is possible or not possible in this juncture. See, you are asking about vehicle. They said about pipeline and lorry and all. So we don't know. The realm of possibilities is not known to you at this point. So that's how you make patents, no? I saw so many paper presentations. Do we know OCT can become implementable? I don't know. You don't know. But you don't stop with it. That's why you use rats. So, yeah. Okay, transport. Good. I will tell you the real solution later. I'll leave you hanging like that. Huh? So think about it a little more, and if you have better answers, you tell me. Now let's talk a little bit about what design thinking really is. There is actually a title, okay, but it's not clearly visible. But yeah, for some of you who said you don't know what design thinking is, which is 100% of the audience, and I did tell you a one statement, right? But design thinking is, if you have to take a bookish definition, design thinking is an ideology and a process. What do I mean by ideology? Is a way of thinking. But it's not just a way of thinking, because outside the box is a way of thinking. Is there a process to it? No, not for outside the box thinking. But for design thinking, there is a process. I will tell you the 5-step process to design thinking in the next 20 minutes. Okay, that's what I'm here for, but I'm a storyteller, so we play and have fun a little bit. So it's an ideology and a process primarily instituted to solve wicked problems. How many of you know what a wicked problem is? Yeah, I'll tell you. Wicked problem is something that is like Ravana. You know Ravana from mythology? Yeah. So Ravana is, what is he famed to have? 10 heads. Yeah. So if you cut off one head, 9 heads come in. I think he was like Rana Dagubati from Bahubali, just extremely physically strong that you can't beat him in just one fight. You need to tire him out and then kill him, whatever. So it has 10 heads, right? A wicked problem is like Ravana. It has 10 different heads or more. You solve one aspect of it, 5 different aspects pop up. A general human being language is poverty. How do you solve poverty? Let's ask the most poor person in this room who has a flat in Thane, who has a flat next to the college also. How will you attend poverty? What's your name, Kanna? Lokesh. How will you fix poverty? Yogesh, okay. First, other fix panninga sir. Yogesh. Then poverty. Okay, yeah. Yogesh. How will you eradicate poverty? We know. Thank you. It's like a doctor, right? Pallu seriyilla. Either issue is there. Okay, but yeah, how will you fix it? Give me some ideas, man. Such a poor person living in Bombay, you will know, have some ideas.
Education.
Educate them, okay? Ma'am, let's assume you are poor, which you are not. You have 5 lakhs for a dental clinic. But okay, let's assume you are poor. I will educate you, ma'am. Money is not very important in life. Okay? Money is not, heart is the important thing. Educated.
No. Educate how to earn more.
Oh, educate how to earn more. Okay, educate her, no? No, but I'm playing with both of you, of course. So education is a very good theoretical concept. Education has never made anyone unpoor. Are you poor? How many of you are poor in the house? Raise your hands. Raise your hands, macha. We are teasing Yokesh. You have to play with me, no? Okay, but yeah, education, what else? Employ them, give them employment. Yeah, sure. But you know what happens with employment, right? You get 1 lakh salary, you will say, "Yo, 1 lakh da irukku, pattave illa. I'm not able to afford 2 fridges in the house." What else can you do to eradicate poverty? Someone is saying, food, yeah, give them food, water, shelter. You should eradicate poverty, but you're understanding the concept, right? Poverty is a concept. It's a mindset also. So you can't eradicate poverty just like that. If you give them job, the next problem will be, hey, I don't have the job that gives me enough money. If you give them education, I am educated, I am engineer, but I am driving Swiggy. Sir, why is there a static? Sir, why is there a static or a gus noise coming? Okay. So that is wicked problem. Okay. So in your language, what is a wicked problem? Identifying malignancy. Yeah. From whatever papers I saw, 4 papers I saw. Okay. Identifying malignancy seems to be a big problem for you. If you identify malignancy, you are not sure if it is confirmed. Delhi gunpointirukku. If it goes to Delhi and comes, it takes 10 days. Ma'am, I can walk to Delhi and come back in 10 days. Why does it take you 10 days? Yeah. And then, first of all, you have to trouble the patient to get the tumor out, do a biopsy on it, get the result on it, send it for accuracy again. And right now, I'm only speaking logic. I hope I'm medically right also. But identifying malignancy is a big challenge, no? It's a wicked problem. Can we try any other innovative solution to make these wicked problems solved easier? That is design thinking, okay? Any problem that has multiple branches, can you solve it slightly easier? This one at least you understand? Okay, yes or no? Okay, good. That's the maximum theory you are getting, okay? So there is a 5-step process to design thinking, I told you, right? Here is, anybody knows what the 5-step process is? Nobody should raise your hands because everybody said you have not even heard of design thinking. Okay, so the 5-step process is called empathize, define, ideate, prototype, test. Empathize, define, ideate, prototype, test. And it might look complicated, but how many of you drive cars or bikes here? Geared vehicles? Automatic geared, yeah? Do you remember, is it a car or a bike, ma'am? Car, do you remember when you started driving? They said clutch, brake, first gear, remove the clutch, apply the accelerator, take the legs off the accelerator, press brake, and then at a time press everything. And then you are confused, hey, left mirror, right mirror, straight mirror, the wife next to you, all of it. Yeah, it sounded very complex, no? But today when you drive, I'm hoping you call Abhilasha ma'am and swear at her. Ma'am, enna ma'am class edukringa, onnume puriyala. You don't even know what gear you're driving on after a point, yeah? Every learning is like that. The moment you're introduced to a process, it seems, but then it eventually becomes second nature to you. So remember this in your heads, that is enough. Empathize, define, ideate, prototype, and test. Okay? With me? Anybody taking notes? Not that much worth and all, sir. At the end, you will repeat after me. Okay? Sure. So let's talk about every step. So what I will do is tell you the step, tell you the tools for that step, and give you 1 or 2 obstacles that stops you from following that step. Okay? Stay with me. 2 more slides and then we'll play another game. Okay? Just 2 more slides. So, perhaps the most important step in design thinking. When I asked you the question of what use case are you solving with the invisible aligners, with your, what did you call that, ma'am? That mirror. Mouth mirror. There are some different mirrors, okay? Mouth mirror and of course your dental clinic. Your answers were right, and yet the core of it, 1% got it. This is the core of any innovation, especially design thinking. The title says empathize, okay? In case you're not able to see it visibly, I will change the font color and send it to you. This is where you talk to the user, understand their problem. Innovation starts right there as far as design thinking is concerned, as far as wicked problems go. Ask the user what the problem is, then you can solve it. With me? With me till now? So how can I get and ask the user what the problem is? There are some tools. One of the most easiest tools is a conversation. Just ask them, hey, what is your problem? Right? What's your problem? You know, how many of you know Swiggy, Zomato? You're supposed to raise your hands. Okay, it's a trick question so that I know audience are engaged. All of you know Swiggy, Zomato, right? What are they for? What do they do? Food delivery. Why did they come to be? Yesterday my wife ordered dosa from Sangeeta. You know how far Sangeeta is from my place? 100 meters. You step outside, turn left, 100 meters, there is a Sangeeta hotel. At this point, I must have shut up. I made the mistake of asking her, "Inge dana irukku. Why pay 30 rupees surcharge?" She looked at me and said, "Okay, I will go. Will you take care of this boy, 4-year-old, who is shouting and running around with a water bottle all across the home, spilling water everywhere?" I said, "Okay, possible. I can handle him for like 10 minutes until you are gone." I said, "Okay. Will you handle the 8-year-old who is doing abacus sum, who must not be disturbed at all?" Slightly more complicated, level 2, but okay. Because the moment she asked the question, Max, I only know to talk. So, okay, that is not such a big thing. Maybe I can manage. Then she said, okay, I have a cooker where rice is cooking. Can you count whistles and switch it off after the third whistle? Now it's really getting hot. Okay. So, Sherry, I will delegate that task to my daughter who is doing abacus. Abacus she can do later. She can count. Okay, no problem. All this also fine. Then there is dosa in the tawa. You have to feed your daughter. First of all, flip the dosa. Once that is done, take the dosa off. Make another currandi of dosa. At this point, I lost it. Dosa mavda irukilla. Why do you need it from Saveetha Hotel? And she said, that is ragi dosa, which is for your daughter. You want to eat tasty dosa, this dosa is for you. And I'm like, ida modale salakada. I will take this dosa because I like Sangeeta's sambar. Now, then she asked the easiest question, why can't you go and get the dosa and come? I'm like, I have to bath. I have to mentally get ready for the session tomorrow. Honestly, true story. I said, I have to prepare the slides for this session, which is not even visible to you. So sometimes you're supposed to burst out laughing at this point, but that's okay. But you see, different user groups have different priorities and preferences. What my wife is handling 4 tasks at one point, I am doing mental work. She's doing physical work. I am doing the more difficult tasks of designing PPT and all. And so Swiggy and Zomato helped us yesterday. So to each of us, the problems are understood differently. The use cases are totally different. That is why the first step to any innovation is understanding the user. Okay? Have a conversation with them. What are some of the obstacles? Why do most of us fail when it comes to patenting, filing an IVD, submitting it, even doing any kind of innovation at home? Is we totally skip the part where the customer is concerned. Except one person in this auditorium, nobody said the mouth mirror solves the problem for the customer. If you don't have a mouth mirror, I should do inverted pranayama yoga for Abhilasha to check my mouth. Yes or no? There is a teeth right back. How do I show it to her? How does she treat me without damaging any other cells or nerves or teeth in my mouth? But except one person, none of you said it is solving the problem for a patient. That's why we fail. Some of you, I really, the word OCT stuck in my head. I don't know the full form. One of you presented that paper. I don't know if she's here. I don't see her here. Where she said we can use non-invasive techniques to identify if there is a malignancy inside. And how do you do that? Our judge asked the question at the end because I was very curious. Can this light penetrate a bone? A beautiful question, sir. I understood that fully. And then she said, yeah, this light is very soft, and she gave a frequency of that light, 500 to 700. That also stuck my head. Why did it stick in my head? I have no medical cell in my body. The one doctor I have never gone to is the dentist, because scary, man. The first thing I go when a doctor, go to dentist, they put an injection in the ear. I've seen patients, I've never gone in. I'm scared. But every word of the conversation between sir and the ma'am who presented stuck in my head. Why? Because I found, okay, so next time my relatives want to go in for a check of malignancy, is it possible that you don't put an injection and then surgically remove a biopsy, suspect, but instead just put a torch inside and then find out? It is for a customer. Okay, so if you skip that level entirely, you are setting up yourself for failure. And then second, too many assumptions. How many of you have actually gone to a dentist to get treated? I asked the wrong question. How many of you have never gone to a dentist or are scared? Why have you, Yogesh, the return of the king? Okay, I will go to someone else. Ma'am, you have never gone to a dentist? Why not, ma'am? Oh, obviously not required. Okay. Anybody with any other reason? Because I will tell you one reason. I have never gone to a dentist because I'm scared. Just scared. Seriously, I'm scared. I don't know. My mom gave me, every time I have a toothache, no. My mom says, hot water, lavangam, it will be okay. I take it. I don't know if I'm okay, but mentally I'm fine. I don't know. I'm speaking to a doctor, so I have to be careful. But there are so many people in the country, right, who don't, either they don't have the money or the infrastructure or they are scared to go to a dentist. Why? Yeah, find it out. So don't assume. Because you don't have pain is an assumption. Maybe I've used to that pain. There are people who live with their knee pain forever, saying all our moms and grandmoms, and usually like you don't know. I don't know. First time a dentist saw me was in my wedding reception, shaking hands. Okay, she came close and said, "Raghavan, you need a floss." I don't know what that means. I only heard that word. It has stuck to me. And then I asked her a week later, "What will happen?" She said, "You may have slight bleeding, but it's okay." "No, bleeding, ah? Thank you. Sir, I need definitely a different mic. Either yanakku mic ko vastu sari illa, or yeah, let's try that. The orange was good. I will try that orange. I like anything with colors on it. Mic testing 1, 2, 3. But that was louder. Can you increase the level on this? Yeah, just try to increase the level on this. Check mic testing. Yeah, should be okay. People online, if you're watching me, I hope you can hear me as well. Okay, good. So that is empathize, the most important step in any innovation. If all of you go home, forget everything else we speak of today, okay? Remember always in your head to empathize. You will become future doctors and dentists. When the patient comes in, ask them, how do you do? What's going on? It might take 5 extra minutes of a conversation, but that's okay. Because we will tell you all our life problems. No, we won't, but at least we will tell you what exactly is our issue. So that is step 1, which is empathize, okay? Now that you have empathized, you need to sort of translate what you have heard into the real problem. Let us now take someone with the braces, right? Sir, you are the one with brace, right? Let's take the Invisalign example. Not my intellectual property, but I'm taking their example, yeah? You know Invisalign, right? All of you? Anybody who doesn't know what this Invisalign is? Yeah, it's the transparent braces. You call it differently. Now, let us go reverse engineer on how Invisalign is actually a design thought, design thinking output. Okay, somebody design thought and then Invisalign came about. So let's go reverse. So now he has a brace. You have to talk to him. He is our sample. Sir, your name? Sorry? Darshan. Darshan is our sample. Okay, sorry Darshan, you don't have a choice. We are going to talk to Darshan about braces and then figure out why Invisalign came about. Okay, so Darshan, I want you to tell me what is your problem statement. Why are you wearing braces? Common audience answer, okay. Irregularly placed and all is you are a dentist also. Huh? Something wrong with your teeth. You go to a doctor. They say the shape has to be corrected. So they have given you a braces. This brace, is it very comfortable? Don't say yes, say no. No, it's not a pleasant thing, no. There are wires and barbs and steel and trauma and ghosts of girlfriends past, everything inside, no. You put it in, yeah, and you can't remove the braces every day, right? And so so in which version of your life has it become easy? How are you saying it is comfortable? It should not be, no? You only said it is. Okay. Are they comfortable? Say no, macha. No, they are not comfortable. Okay. Why are they not comfortable? Just out of curiosity now, tell me the truth. Other times you don't even know that it is there. Huh? Other days. Now only you said I am in pain, I am not in pain. So what is this? You told that parties get used to pain. Oh, உங்களுக்கு வந்தா ரத்தம் எனக்கு வந்தா தக்காளி சட்னியா? Okay, so you sort of get used to that, yeah? So now this is your use case, this is how you are living. And assume that he wants a different kind of a lifestyle. So you're talking to him, he's saying, yeah, but there is something always here. I can't remove it easily my own self. And every time they change it, the pain is excruciating. So now you have to design a replacement. This is how you define the problem next. We have understood from him that, hey, and especially when I smile, the other person can see I am wearing a braces. So not just you who knows there is a displaced tooth, everybody else also comes to know. Yeah. And so your use case is, okay, that's my trouble. So everybody comes to know I need something else and the pain is high. You have empathized, you have understood the different dimensions. In the define phase, you put them all together and you create a defined problem statement. My problem statement is, how can I set right my mic without me having to fumble so much? Create a collar mic. There is a collar mic. Sir, collar mic work aguma? Almost the same thing. These are braces. That is a Invisalign. Let's see if that works. Mic testing 3 2 1. Sir, loudness கொஞ்சம் increase பண்ணி கொடுங்க. Loudness increase பண்ணா interference வருதா உங்களுக்கு? ஏதோ ஒரு somebody is talking non-stop. That is me only. Is this better? Can you hear me still? Okay. That is still a static, but that should be okay. So we have empathized with, sir, your name? Sorry? Darshan. Yeah, we have empathized with Darshan, understood he actually does have a problem. In your mind, you should fix. Braces are not comfortable, okay? Appada Abhilasha will accept. So in your mind, we have understood there is a challenge, and then we have defined it to say the challenge is it is visible when someone else sees. Every time they change, it is excruciatingly painful. So can I create a replacement for it? That step is called define phase. Okay, you don't need to understand all of the other literature there, but what are some of the obstacles or challenges of this phase is you are too broad or too narrow with your definition. Sir, braces are comfortable only, sir. That is too broad. That's too much of a generalization. I have met 1 lakh people in my life. 99,999 people have said braces are uncomfortable. The other 1% is Darshan. So people have usually told me braces are uncomfortable, right? So don't be too narrow. Don't be too 1% specific. So if I go only to Darshan, I have nothing to solve. Braces are fine. Let us increase the price. 30,000, 50,000. Everybody will buy. So don't be too narrow or too broad. And not framing the problem in a user-centric way. So many of you said, Invisalign aligns your teeth. Can you now try and figure out another reason why Invisalign exists in the world? But Darshan says it is comfortable only. There is another use case. Why have they named it Invisalign? It is not align invis. It is not alignment character. It is invis align. Ladies and gentlemen, the biggest driving factor for you in the world is your pride. It's your ego. It's a good thing. When that gets hurt, that's why Invisalign retails for 1 lakh when normal braces are 20,000. Because they are not fixing your teeth, they are fixing your ego. They are ensuring you feel proud. They are ensuring you can smile happily. That girlfriend you are pursuing, she will not look at your braces first, she will look at your teeth first. True story, Avacha. Suddenly he is interested, sir. Nana. It fixes your ego, and because it is customer centric, there is a market for it. You know, one of the costliest patents in your dental industry is on that Invisaligner, right? It's really expensive. And so always define a problem in the user-centric way. Why should your dental clinic setup cost you 5 lakhs? A general physician next door has a hole in the wall. Nothing, or stool, not even comfortable for me to sit on. He prescribes Dolo 650. My mom prescribes that every day. I pay him 500 rupees every time I visit him. Because he makes me feel comfortable also. Because he says, Vanga Raghavan eppadi irukeenga? And then before I say anything, he takes up the notepad, writes Dolo 650. Adu ezhinodane mind, okay, appada Dolo, constant companion. Always be user-centric in whatever you do. Okay? So define also in a user-centric way. Now we go to the next story. We have still not fixed the mic. But sir, konja volume idu light ah ethalame, konja satham little bit, sir. Oru point ethala. Okay, now another story, okay? Another true story. Ready with me, all of you? Suganya ma'am, inga Dr. Suganya. Next story. Sorry, I know your name, Martninga. Okay, next story. Okay, again another true story. This happened in, thank you sir, it works now, in an airport in Sweden. How many of you know Sweden? I hope you are an Indian from Sweden. You are a Swedish guy from Sweden. You are not Indian. This is called design thinking. I could have assumed, right? From Sweden. Ah, okay, from Sweden. Where are you from, sir? Turkey. You are a Turkish citizen in Sweden. Which part of Sweden? Stockholm. Yeah, that's. No, I know. The name of the airport is that. So I'm going to flip it, okay? Because you're not dealing with real names here. Let's go to Karlskrona. Quaint town, about 3 hours, give or take, from Sweden, okay, from Stockholm. Yeah, but there is a town in Sweden. Let's call it Karlskrona. It's a real. They have an airport, okay. Now there is another place called Lund in Sweden. Yeah, slightly far from Stockholm and Karlskrona as well. Or you call it town A, town B, or Karlskrona, Lund, whatever works for you. Now, the town planners of Karlskrona, they renovated their airport recently. Okay, they spent a lot of money. They redid the entire real estate. They brought down the roof. They made it nice, convex or concave, whatever you call it. Gives it a huge look and feel. They relaid the floors. They made the entire lobby long, and then they put up these escalators right at the corner. Some foot stalls and these corners. They have a battery operated car for people to go up and down, and then a walker later running down the spine of the lawn so that people need not walk all through. Some seating areas sparsely placed here and there. Restrooms, really nice restrooms at both corners of the entire airport. Just really made it superb looking. Signed MOUs with multiple airlines for more flight connections, and they opened it grand fashion. Like India, they called politicians to open up and everything, and then they opened and they waited for more footfalls to come. And then Lund, which is quite far away, about an hour's drive from Karlskrona. There is another airport, smaller one, very few connections, but operates, functionally works. Okay. Now the thought process was Karlskrona will become so good that people will close down Lund airport, maintenance costs are saved, and everybody will go to Karlskrona to fly out. Then they opened it. 1 quarter after opening, they realized footfalls were falling. People were actually not using this airport as much, but rather taking some trouble to go to Lund, take a connecting flight out to Stockholm, and then from Stockholm fly out. Why would people do that? And so Swedish government authorities become a little nervous. So they again called in design thinking practitioners to help solve the problem. We went in and then we observed for a full day. 8 hours we sat in the airport, and these were our observations. Now it's not like people are not coming to Karlskrona airport. They were, right? And families were coming, husbands, wives, solo travelers, college students, university lecturers. So many people were traveling, but there were some observations we observed. So people are all coming in, and then because Sweden is usually lightly populated, unlike India, the kids, right, were just running around and around and around the airport, just screaming, making noise, usually very un-Sweden-like, because they are usually calm. But then the kids became really shouting, they were playing, running around, falling, breaking things, much to the irritation of the parents. Old people were sitting and they were constantly complaining. The men especially, the men were the curious case. 25 to 40, usually leading the pack, sometimes even solo. They were constantly irritated. They were on their phone, just irritated all the time, walking up and down, up and down, up and down. And strangely, every 20-25 minutes, they are going to these restrooms in the corner. They're walking all over to the restrooms, using the restroom, coming back again, and then again irritated face, fighting with the wives, running with the kids, and then again going to the restroom every half an hour. They were really very irritated. And so obviously, because the customer experience is so bad, footfalls were falling. Now, what will you do to fix this problem? Just told you for half an hour. You tell me. I have given you a full scenario statement. Yeah. What will you do now? How will you fix this problem? Set up a playing area so that the kids can sort of be relaxed. Whether the kids are happy or not, we don't know. Abhilasha ma'am is immediately happy. Oh, God, okay, yeah, play area. Okay. What else? Decrease the waiting time, yeah. Make sure there are enough gates, enough departure gates. I wish traffic control was that easy, but sure. What else? She is phoning a friend. Hello, Sweden, huh? No, but yeah, what else can we do? Increase foot counters, yeah, give them some engagement, and then doctors only will come and say, hello, portion control. Foot counter also you will open, portion control also you will say. Okay, yeah, good. Put up food stalls. What else? Some shopping. Your quota of answers, wait ma'am. Let's hear from you. Because you are giving all right answers. I want to hear from you also. What else? Ma'am, in blue. Yes, the one you are sitting in attention. I know I look really nice, thank you. But yeah, what will you do? How will you fix it? Karagatam, Mailatam. Yeah, put up some entertainment stalls in the airport. Actually, in Chennai airport, there are multiple TV screens, right? There is no space for people to walk only, but there are TVs that show matches. Yeah, good. Thank you, ma'am. What else? One more answer. Loudly. Increase the number of restrooms. No. Why are you making them walk to these far? And she's like, I told you. No, I told you. Kaha tha. Ma'am, what's your name? Huh? Yeah. Can you pass the name to me? Alva. Huh? Arva. A-R-V-A. What does it mean, ma'am? Good soul. They didn't design thing and all your parents. You are born to me, you must be good soul only. Arva. But I am a bad soul, I don't care. Arva. Okay, fine. Yeah, Arva says, I told you. Bloody listen, huh? Doctor is talking, listen. Yeah, increase more restrooms, no? Why do you want to make people walk so far? Like I always do, I'll leave you hanging for a little more. I'll come back. What are the 2 steps to design thinking we have already seen? Empathize and define, right? Okay. Let's go to the 3rd step, where even those who have ideas fail. Many of you gave solutions, right? And while giving a solution, some of you asked, is this even possible? You were asking, right? Why is it not possible for me to put up a transport from the water place to lorry or whatever, right? You know the biggest failing for a common Indian? We fall into what is called practicality box. Is this practical? Is this even doable? You know why we do that? Because in the morning when you wake up and go to your mom happily and say, Amma, today please make sandwich for me. Amma looks at you and says, time illa. Upma. How many of you like upma in the house? The door is that way. I don't like toxic people in the room. No, but yeah, because they are said, hey, ask something that is possible, doable. In the rush that we are in, I can't keep making elaborate sandwiches and biryanis for you in the morning. Upma it is. Upma is not even a dish. It is what people make when they don't love you enough. How many of you like upma in the house? I just now said your mom doesn't love you. Listen. No, but yeah. When we sort of start thinking of ideas, the one question that comes to all of our minds immediately is this doable? Is this even an idea? That's why Arva was like, I told you more toilets. But you said, will this even be an idea? And then you stopped it. So when it comes to design thinking, the philosophy that they give you is throw in quantity, forget quality. Just throw in as many ideas as comes to your head. Don't worry about doable or not. What is the budget? What is possible, not possible? I want to remove the mic and speak without mic. Except the online audience won't like it. But in this phase of design thinking, you only think of quantity. Just throw in ideas. Just keep throwing. Don't think. I will tell you a classic example of an idea that is wild but worked. How many of you watch movies? How many of you watch movies? Trick question, entire hall, okay. How many of you watch this movie called Endiran? Rajnikant movie, right? Yeah. For promotions of Endiran, sir, can we switch this off and can I try without the mic for a minute? Check. Oh, live is correct. Oh, here the static is there. Let me see if this is a problem. We will talk. But it is or the other issue. Check 1, 2, 3. Okay, yeah. Okay. How many of you saw this movie Endran? Endran, most of you saw, right? Usually, when promoting a movie, what do people do? They go to interviews. In Turkey, they drink Turkish coffee, maybe, I don't know. And then they promote a movie. You know what they did for Endran? Somebody skydived with Rajinikanth's poster held in their hands. Two people jumped. Abde sky la full Rajinikanth poster. Movie promotion da. Budget of 2 movies is equal to that jump. And then they also did this, what is that? Burj Khalifa. Entire Burj had Rajini's face. And then of course Kabali, you should all know. They painted a flight. If they had spent 1 more minute extra on screenplay, movie would have been at least nice, no? But they did all that, right? So people don't, first of all, when you come up with ideas, don't ask, is this possible or not? Go for it. It's almost like love. You don't even know if the other person will like you or not, but you start loving, no? So just in this step of thinking, once you have empathized with the customer, once you have defined it in their way, throw in ideas. Just as many ideas as you can, throw them out. Don't think at all, just put in ideas. What will you do with it, sir? I will tell you later, okay? But just do as many ideas as you can. There are some games we play called time boxing. 8 minutes, as many ideas as you can get, throw it out. Just throw. For next 8 minutes, you're giving me ideas after ideas after ideas. Arva's parents didn't think that much and all. I want a name starting with the letter A, meaning good soul. First Google search result, Arva. But generally, when parents want to name their kids, it's a 6-month process. Because the wives never accept. Yes, sir. What do you name your, are you married? You have kids? How old is your child? 12. Unga child dana? She's like, 1 minute. 12 and 8. Did you name them or did your husband? What did you name them? Ishan? Ahan. You named them because they're rhyming, huh? Okay. What did your husband suggest? Ramu, Somu. Men are easy like that. Ram, Sham. 1, 2. Huh? They don't have. Yeah, we know you will shoot it down. But anyway, I'm kidding. Good love for Ishan and Ahan. Good names, by the way. We also call what is called sketching or brainstorming, or it's called 8-8-80. I give you 8 minutes with a team of 8 people. Try to come up with 80 ideas to solve a problem. 80 ideas. The Darshan is lying and saying the braces are comfortable. But what will you do to make Darshan's life easy? Something like there will be someone always accompanying Darshan and saying you are fine. Idea, put it in. Give Darshan 1 lakh rupees. Or make our judge sit next to Darshan. Judge will say, hey, you are comfortable only. Darshan will say, okay, I am comfortable. All ideas are fine. Throw ideas in. Okay? So that is the third and most important step of design thinking after empathy. Second most important. What are some of the obstacles? Falling into the box, thinking very usually. If usual thinking happened, there will not be a plane with Rajinikanth's face painted on it. That plane had a 2-year longevity, and then that's it. They stripped the plane off that poster. So much money they spent. So don't fall into the box don't have a practicality trap. Don't go into the upma zone. Always think of fresh ideas and create new ones. Then comes the penultimate step where you go into prototyping. Can I give you a game now? She's like, Kandipa Veduma sir. Rumba lenta podu sir. No, but I'll give you all a quick game, okay? I want you all to Google for a picture of a paper boat. Google for a picture of a paper boat. Show it to me on your phones. Quickly. Chat GPT it, no problem. Use your phones now. Thank you for not using it till now. Sir, where? This is the camera, right? So if I step off stage also, it's fine. You don't even have to follow, but I'll go into the audience. Ma'am, show me, please. Unga pair, ma'am? Chandramukhi. Ada, the expression in her face was like, ayyo, game. But yeah, Chandramukhi, ma'am, yeah? Paper. Oh, for sheer cheek. She took the paper boat juice, beverage. Okay. Oh, some of you did. I meant a playing boat, yeah, that you put on water. Something like this. Paper boat, yeah, boat, not the paper boat beverage. Boat, or what do you call it? Couple, Kagida couple, whatever. Okay, some of you show me, quickly. Okay, nice, good paper boat. Good one. Which one, ma'am? Ma'am, pick one. Okay, green, okay. White, okay. What's your name, ma'am? Divya Shri shows me, which one? Blue one, okay. Divya Shri, okay. Anyone else? Arva is like, I don't care about you. Pick one. That one, okay. What's your name? Molly. Sorry? Molly, okay. Molly and Divya Shri, I'll remember. Okay, boats. Okay. Oh, both of you together. You are comfortable with the braces, okay. Thank you. Okay. Any boats in the last row? Okay, super. So, nobody really won this game. What are you showing me, ma'am? Are you showing me anything? Nothing. She's not. Okay, that's 1, 2, 3, 4. Okay. Yeah, well done. Give yourself a big round of applause. You know how to use Google. Well done. Yeah. Molly and Divya Shri. If I had chocolates, I will give it to Molly and Divya Shri. I'll tell you why, okay? I wanted you to show me a blue boat with I love Raghavan written on it. How many of you showed me that? Why not? Because we didn't know. Did you ask? End of story. Sometimes our intelligence is our biggest enemy. Some of you went to paper boat also. Yet, the easiest thing to do would have been, Raghavan, you have been playing with us from the moment you started. You only tell me what exactly do you want. Sometimes we don't ask. Next time, ask, then your prototype will be effective. Now, all of you have spent time on your prototype. When I play this game on a one-day session, I give them all newspapers and ask them to build a boat. At the end of these 15 minutes, we have outstanding boats here. Like double-decker boats, boats with a sword, boats that can fly. People bring bucket with water and float the boats. All kinds, but I've never gotten a blue boat with your name and I love Raghavan written on it. Because as humankind, we are all the same. The moment a challenge comes in front of us, we take over. Our intelligence, our capabilities, our understanding, our knowledge, our smartness comes in. But hey, design thinking tells you to flip the mirror. It's not about you, it's about them. Remember what I started with? It's not about what you can do, it's about what the user wants. Okay? So when you prototype, keep them in your minds. What are some of the obstacles? You add too much complexity, you go to paper boat beverage and all, or you spend too much money or time figuring it out. Okay, let's now come back to the airport. Now I have told you a game, I have told you an activity. You tell me, what will you do now? Let's assume you're asking me. What will you ask me?
Why are you irritated all the time?
Philosophically, because I'm married. No, but I'll tell you. When they and you have asked the right question, they're given the answer. I'll give you the solution, okay? When they renovated this airport, they changed everything. They curved the roof, but they did not any sound absorbing material anywhere. And so when people entered the airport, right, there is a gentle music playing all the time, no? It is bouncing off all of the walls and it's irritating. When I told you the story, the storyteller I am, I sandwiched the important things in a small package, threw it out, and distracted you with flab. I told you, Swedish kids are not usually restless, but they got restless. Why? The sound. And why are old people angry when they are sitting? Because, why is this noise all the time? And then the big piece of the puzzle. Why are you using the restroom all the time? What age group are these men? I told you, what age group are they? 25 to 40 are not men who use the restroom all the time. Yet they do, because along with the music, when the flight announcements come, you can hear practically nothing except noise. So why the restrooms? Because the restrooms have the false ceiling. And the speakers in the restrooms are clearer. Real life story, my dear friends. Real story. And so, how did we fix it? We just put some sound absorbing material 8 different places in the airport. Not play areas, not extra food stalls, not Karagatam, Mailatam entertainment and all. We spent 5,000 US dollars. Problem solved, footfalls increased, everybody is happy. Why am I talking to doctors about flights and airports? I'm not talking to you about flights and airports. I'm talking to you about people. Next time, ask what people want. Answers will come better. Okay? Which brings us to the final stage of design thinking. What are the first 4 stages? Empathize, define, ideate, prototype, and then finally test. Okay? This is where you take the solution, go to the customers, ask if the solution works. The ability of design thinking is being able to pivot. If at any of these stages the customer says, "Illa, this does not work," it's okay, throw it out. Because you have only spent very less time and a lot of customer-centric thinking only. So you have not spent so much money, hopefully. Okay? And so some of the obstacles here are denial to pivot. Adallam kadayadu. Arva is the only name I will keep. Arva is a good name. But if you see feedback that is coming up against you, don't be hesitant to change. Don't be in denial. Okay? That is an obstacle. Don't ever do that. And finally, listen to people. If you don't, if you let your human intelligence take over, more chances you will fail. Good. Now let's go back. I already told you why you use the entire setup, right? Why is this entire setup needed? Oh, the one person who answered correctly is not in the room now. You know, your entire dental setup has one function only. You know what it is? Customer comfort. This costly chair is not for you. You don't even sit in that, no? I sleep in that basically. All these fancy equipment, not for you. If they write something in A4 sheet of paper, you will understand. Your handwriting, I also don't understand. But her handwriting, you will easily understand. Ida ma'am solla varanga. Her, what is her psychological state, what she ate for breakfast, dinner yesterday, and all you will know from that handwriting. I don't. But All of this is for me as a patient. So you are walking and living around a setup and an institution and an education system that has me as a user in the center, and yet you forget me comfortably. In none of the presentations I heard a word saying about a patient. If I were you, I would have said that first. I would create those medicines not for all the scientific reasons, but hey, because my patient needs anti-inflammatory elements in him. I loved your presentation, especially, ma'am. But I wish to hear something about me. And I'm sure if you had spoken that, even our judge would have immediately connected, because he is also eventually someone who's going to consume your creation, right? So next time you write in a paper, add a slide, one pager, one worder, one sentence about who this is serving. And then we go, of course, to the, that's a summary, empathize, define, ideate, prototype, test, but the protagonists of the afternoon, of the morning. I know what you are going to say, but what would you say now? How do we solve the problem? Sir? How would you, now that you know empathize, define, ideate, prototype, test, how will you solve their problem? Sorry? All of you will ask them? We did that too. You want to know what I heard? Yeah? Sir, 2 minutes, because hey, they deserve our undivided attention. We asked them, and they had tears in their eyes. Because they said, hey, you are a man, and you're asking me. And then they cried. And then after they stopped crying, you know what they told us? They said, sir, do anything. Ma'am, can I have you for 2 minutes, ma'am? 2 more minutes, I'll finish. He will also like what we are talking about. You want to know the solution, right, sir? Yeah, 2 minutes. We asked them, and they said, sir, do anything. Bring about any solution. Use your technology. Use your magic. Use all the money you have in the world. Fix something. But please don't that 12 p.m. to 3 p.m. of our days. Don't do anything about it. Don't touch it. Please don't do anything about it. And at this point, I lost it. Because I had come up with 17 ideas, 17 ideas to fix their problem, and all of them were something to do with 12 to 3. And I was like, what do you mean? They said, sir, yeah, we are having a very difficult life. Yes, it's physically tough. But this 12 to 3 of our lives, that's when I meet my friends. That is when I can live life as a woman. That is when, the heat we are used to. I was born in this heat. My mom put me on this floor naked. My skin has grown on this hot sand. This heat doesn't trouble me at all. 12 o'clock, I'm waiting for that time in my life, because I can gather all the clothes, take all the pots, and all of us women, we talk and have fun and joke and gossip. We are treated like human beings by each other. And we go to the pond, and there is water. In the heat, the water is outstandingly gentle to us. We play, we have fun, we roll around. There is no man in the vicinity to watch us. We are happy. And we put the clothes to dry, and we lay back and then eat some chips and chocolates and laugh and joke. We brainstorm Ishan and Ahan names. We bitch about each other. We are very happy. And then while walking back, sure, our heads and shoulders are heavy, but our hearts are light. If you rob us of that period, we have nothing left to live. Again, Raghavan, the storyteller, threw in a gentle stat to you. You missed it. I said everyone has suicidal tendency. Did I tell you anything about anybody committing suicide? And they said, if you took away that 12 to 3, we have nothing to live for. I lost it. I cried a river that day. But we still didn't have a solution. We were overwhelmed to ask anything, so we asked for a meeting the next day, and then the next day we said, thank you for opening our eyes, but how do we fix this? What do we change? And you know what they said? They said, sir, we are used to this life. I mean, we are used to our husbands not even looking at us. Our husbands don't even ask, have you had food? They don't even look at us. That's our faith. That's okay. But our kids, they watch these husbands and they think we are machines too. They don't help around the house. They don't help with the cattle. They don't do any of the chores. They don't even respect me as a human being. So please, talk to our kids. Tell them your mom loves you. Tell them what it means to be a good human being. Teach them respect. The irony is we went in with 3 crores of money as the budget. We spent 3 hours under the tree, in the moonlight, giving philosophy classes. Problem solved. Ladies and gentlemen, I present to you the soul of design thinking. Which is you and you and you and you and you and every mom and every aunt and every family member who has sacrificed their lives for you. So we are talking about something scientific. We are talking about a process, but we are talking about an ideology as well. So tomorrow, if you can think for them, you will be outstanding doctors, but the best human beings all around. Thank you, SDC, for having me here today. Thank you, ma'am, for inviting. Thank you, Dr. Sandhya, if you're watching, for having me here. If you would like to connect, I am on all these. Thank you so much for having me. And back to Abhilasha, ma'am, because I like you a lot. Thank you for being so responsive. Is there a MC that I have to hand over the stage to, or I will hand it over to you only? Yes. Thank you, ma'am. You have a mic?
Thank you very much, sir, for a wonderful and very interactive and lovely session. I'm sure all of us loved it. Yeah? So we can all give a round of applause to sir again.
I take a selfie with every one of my audience, and I also ask them if they like the session. If you like it, you clap. I will take a video. Okay? Did you like the session, guys? I definitely need a selfie with all of you, okay? Put on your most cheering face. Ma'am, you two behind me. Ma'am, turn around, yeah. Show some gang signs, make some noise, guys.
Yay!
Very good, very loud. Thank you. Thank you.
I invite Dr. Pratibha Ramani ma'am, our HOD ma'am, to kindly give away the certificate to our speaker.
Thank you for that wonderful lecture, Raghavan sir. It was very, very engaging and super interactive. I really wish a very awesome journey to you as an orator. We really enjoyed listening to you. And dear participants, both offline and online, we'll now quickly break for the lunch and then resume back for the student and faculty presentation, which would be aired live. The offline sessions will be aired live and will be on till our valedictory session, hopefully to complete by 3:30 to 4 p.m. So we'll resume back again after a quick lunch session. Thank you.
So good afternoon, everyone. Here we'll continue our fourth technical session, and the session is chaired by Dr. Arul Prakash, Associate Professor, Department of Biochemistry in Saveetha Dental College. The first speaker of the fourth technical session is Dr. Akshara Modak. Here to you, Akshara.
A very good afternoon to one and all present here. A very good afternoon to one and all present here. My topic is comparative efficacy of TGF-beta inhibiting herbal compounds and traditional antifibrotic treatments, a systematic review. So now in the Indian and Southeast Asian population, due to a prevalent habit of chewing pan, which is known as areca nut, is one of the most prevalent pre-malignant conditions that is seen in our Indian population is oral submucous fibrosis. So where the patient presents with, at advanced stages, there is severe thickening of the inner lining of the cheek, that is the buccal mucosa, and in severe cases, it will lead to inability to open the mouth, very restricted mouth opening, burning mouth sensation. The patient is not able to eat any food, and the quality of life becomes very poor. So fibrosis is not yet cancer, it is just before cancer. So and this is not, in dentistry we predominantly see fibrosis in the oral cavity, but we also see fibrosis in several other organs. The current treatment for oral submucous fibrosis is not yet well established. The main treatment they offer is to stop the habit, and they give some immunotherapy like drug supplements, lycopene, antioxidants, but that still does not cure the patient's problem. And this is seen in liver, lung, and many other places. So one of the key factors that cause fibrosis is a growth factor called TGF-beta. So elevated TGF-beta levels, they are related to oral submucous fibrosis, and so the current treatment options that they have is like lung transplant, which is a very extensive treatment, and not all patients are willing to do that. So for that reason, since we are looking for more treatment options, in herbal medicine has been used in centuries for treatment of several diseases, and there are lots of herbal medicines which are TGF-beta inhibitors and have been proved to reduce collagen deposition. So we did a systematic review, not just restricted to the oral cavity but to all organs, to see, and this systematic review aims to assess the efficacy of these herbs which are TGF-beta inhibitors compared to other anti-fibrotic treatments that are being used. How is their efficacy on fibrosis? And we primarily focused on animal models. Our research question is, what is the efficacy of TGF-beta inhibiting plant or herbal derived compounds compared to traditional anti-fibrotic drugs in reducing collagen fibrosis? This was our aim. We included animal study as our population. Our intervention was a plant, which is a TGF-beta inhibitor, compared it to a placebo or other traditional antifibrotic drugs. And we checked if TGF-beta levels were reducing or not, and if there was reduction in fibrosis. Coming to materials and methods, the same thing. We focused predominantly on animal studies, and we excluded those studies which were only on in vitro or cell lines. These were our search terms from PubMed, Web of Science, and Scopus. In the Prisma, initially we found 873 articles. After removing duplicates and we screened around 284 articles. From the 88 that, from that 88 met the eligibility criteria. And then from further going through those records, some of them were using TGF-beta only to induce fibrosis, but they were not assessing those pathways. So ultimately 30 studies were included in our systematic review. Since we were primarily focusing on animal studies, we used Quality Assessment Circle, that is Systematic Review Center for Laboratory Animal Experimentation. What we found in this quality assessment was that methodological details of the animal studies related to random allocation procedures, whether the investigators were blinded or not, how was the animal handling done, that was not provided clearly in several studies which we went through. But however, other information about how fibrosis was induced and the age, weight of the animals, all of that was documented very properly. So coming to data extraction, we actually divided our 30 studies further into 4 groups based on the method which was used to estimate the TGF-beta levels. So most of them used Western blotting. Around 18 studies used Western blot. Remaining studies were PCR and ELISA, and only 2 studies were primarily focused on histopathology. So they took the tissue after inducing fibrosis and after giving the drug, and then they compared with scoring, like this one fibrosis is reduced or not reduced. So that was done only in 2 studies. This was the information which was taken from data extraction. So type of studies, around 25 out of 30 focused both on in vivo, that is animal, plus in vitro studies also followed. 5 studies primarily focused on animals. Then we checked the sample size was mostly in animal studies. They used around 6 to 10 rats and used around 4 groups. So around 40 to 60 rats or mice, which were the most commonly used animals. The most common site which they had done studies for is lung, followed by liver, and then kidney. After that, very few studies were done on oral submucous fibrosis. Method of inducing fibrosis was predominantly bleomycin was used to induce the fibrosis, and in some studies they used CCL4. There were very less studies on OSMF, so there were not many areca nut induced fibrosis which were studies that were done. Then most of the studies were conducted in China, Japan, Korea, India and Iraq. So the main herbs that we used include Cordyceps militaris, which is a herbal TGF-beta inhibitor which is found in Himalayas. That is one of the primary mushrooms which were used for TGF-beta inhibition. Then accordingly there was Curcuma longa, Centella asiatica. These type of drugs were used, mostly marine drugs, and they isolated their compounds and checked whether TGF-beta levels can reduce or not. In all the 30 studies that we checked, TGF-beta expression was reduced in all of them after compared to the placebo. In all the 30 studies, there was reduction of TGF-beta. Along with that, other pathways like SMAD2 or 3, which is related to TGF-beta, that was also reduced. Alpha SMA collagen 1 was also reduced. They also checked other pathways like PI3K or AKT, MAPK pathway. All of them contribute to fibrosis. So even that was seen to reduce by using these herbal compounds, ultimately reducing extracellular matrix deposition. Therefore, fibrosis was reduced even histopathologically. So coming to the discussion, TGF-beta plays a central role in collagen fibrosis, and based on the studies that we reviewed, targeting this particular pathway can be of use to reduce fibrosis, and it is lesser, since we are giving these drugs orally or intralesionally, this can be little less invasive compared to if we can systemically treat the patient rather than going for direct transplantation. So the limitations of our study was we only used studies in the last 5 years. the only studies, we only used studies which were reducing TGF beta levels. So we did not focus on the other pathways like PI3K or AKT, which also contribute in fibrosis. So we did not check that aspect of reducing those, will it also reduce fibrosis? And then since there was heterogeneity, different types of like Western blot was used and qPCR, so we were not able to do a meta-analysis for this particular result. So conclusion was that herbal and plant-derived compounds, they demonstrate a strong and consistent antifibrotic activity by reducing TGF-beta. So targeting this TGF-beta pathway can be a potential therapeutic option for fibrosis and can be implemented in oral submucous fibrosis in the future. These are my references. Thank you.
Yeah, nice presentation. And actually, I have few questions because you have answered for one, that TGF alpha, you have only chosen that.
Yes, sir.
So is there any specific reason for choosing that?
Sir, we chose TGF beta particularly because in oral submucous fibrosis, the pathogenesis that we study, TGF beta plays a central role in it. So we wanted to target TGF beta, and we also found that it has a central role in all types of fibrosis. There are more pathways that are also contributing to fibrosis, but since this was even an active component for oral submucous fibrosis, we selected TGF beta.
Okay, so what is the pathology behind fibrosis?
Sir, TGF beta, it activates this SMAD3 or 4 pathway. Along with that, it has a synergistic effect. It activates even PI3K pathway, and all this causes myofibroblast activation. So that will cause extracellular matrix deposition, which will cause fibrous thickening inside the inner layer of the cheek. All this is aggravated by chewing areca nut or all these chemical carcinogens which people are consuming daily. So all this synergistic effect together is what leads to thickening. So that will cause, because of such thickening, they cannot even open their mouth. So this is the...
What is the relationship between the inflammation and the fibrosis?
Inflammation in, there is actually a little hyalinization we will see. Inflammation is kind of moderately influenced. There's not that much of inflammation, but we see more of hyalinization in fibrosis.
Okay. So you have reviewed around 83 articles, right?
Around 88 articles we went through. From that, only 30 were properly following our TGF
Okay, did you find any, so these are all reducing the fibrosis. Did you find any combination of herbal with allopathic medicine or any different herbal formulations?
They used very, they've used different types of herbs actually.
Not in combination?
In combination, some of the Chinese medicines, they were used in combination. So synergistic effect will help reduce fibrosis more.
Okay, ma'am.
Yes, sir.
Good. All the best.
Thank you, Dr. Akshara. Next, we have number 7, Dr. Rihanna.
PDF. Mail அனுப்பிச்சிருக்கீங்களா?
Good afternoon, respected judges. Today's topic of my presentation is in silico pharmacological profiling of Bommeria nivea, which is considered to be a promising natural drug pipeline targeting aquaporin and xerostomia. So basically, xerostomia is nothing but a condition called as dry mouth, which is usually associated with many autoimmune conditions like Sjogren's syndrome, and it is also a manifestation of post-operative radiotherapy, diabetes mellitus. Though many conventional treatments exist in everyday day-to-day life, all those conventional treatments, like example pilocarpine, all those conventional methods offer only temporary relief. So here in this study, my aim is to find an alternative, like using a medicinal plant. I wanted to extract all those phytochemical compounds so that it targets directly the root cause of xerostomia, and which will replace the existing conventional therapies. My materials and methods section will consist of four important divisions. First is phytocompound selection. We took a plant called as Bommeria nivea, that is otherwise known as Remy plant. In previous literature, it has already been extensively studied for antioxidant, anti-inflammatory properties. We are using this plant, and from this plant we are extracting 17 phytocompounds, hoping to treat xerostomia. But how we are treating this xerostomia is by targeting one important molecule known as aquaporin 5. Basically, aquaporin 5 is usually present on the apical surface of the salivary gland. So this aquaporin 5 expression is the one which maintains the salivary flow in the salivary gland. So any dysregulation in this aquaporin 5 molecule can cause reduced salivary secretion, that is known as xerostomia, dry mouth. So basically, we are targeting aquaporin molecule using the plant, using the phytocompounds obtained from the plant. So we are checking for gene interaction network analysis and preparation of target protein, and we'll be also checking the ADMET and pharmacokinetics and drug likeliness. Next, after checking the ADME properties, pharmacokinetics, all those are initial preliminary studies. Those are known as computational studies, that is docking. Further, after docking, we obtain 17 phytocompounds which are proved to be effective in treating xerostomia. So we tested those compounds and carried further into cell lines, so that we confirm the results obtained in the docking study. So ELISA and Western blotting were done to check the expression of aquaporin 5, whether those compounds that we obtain from the plant have any significant increase in the expression of aquaporin or not. So that is what we are testing. So these are the results of the pharmacokinetics. These are the 17 compounds which we find closely, which prove to have a good docking score with the aquaporin molecule, and found to be beneficial to increase the aquaporin 5 molecule. That we confirmed it through the Western blot and ELISA analysis. So this gene mania is nothing but, apart from aquaporin 5, there are other water channels known as aquaporin 3, aquaporin 4. So we are in gene mania, we are testing whether the aquaporin 5 is related to other water channel proteins. So what we are trying to do is, when we target one aquaporin molecule, we can indirectly target the rest of the other water channels also. So the drug likeliness test revealed 17 phytochemicals were obtained, and among that 14 compounds showed strong binding affinity, among which the compound known as ursolic acid, which demonstrated high binding affinity. And the other 11 compounds, like example ursotic acid, chlorogenic acid, amodin, also showed favorable ADMET profiles. ADMET is nothing but the absorption distribution metabolic excretion test. This ADMET all tests are required to formulate a drug. So we are checking all the tests through computational methods. So these are the docking structures. So this table shows the binding affinity. As we see, ursotic acid, chlorogenic acid got the highest negative scoring. Negative scoring usually means the binding, it has good binding towards the targeted protein molecule, that is aquaporin here. And this beta carotene, rutin and lutein, which have been obtained from this plant Bommeria nivea, showed the least docking score, and we thereby excluded this. Moving on to the Western blot and the ELISA analysis. Through molecular docking, we finalized 3 compounds, that is ursotic acid, chlorogenic acid and amodin. These 3 showed highest binding affinity. So with these 3 compounds, we wanted to test in cell lines. So we bought human salivary gland epithelial cell lines, and we tested these 3 products that is obtained from the docking result. And we use DMSO as a control. So we gradually increase the concentration from 1, 5 and 10. And we are seeing at, for example, at a concentration of 1 micrometer of ursotic acid, there will be a protein expression of 2.5. So we are gradually trying to increase the expression, increase the concentration, and thereby validating our computational method. So this is the radar chart of how the aquaporin 5 it is affecting. So moving on to discussion, previously many studies have targeted like xerostomia using many medicinal plants. For example, in 2024, quercetin beta citorol from Mumfrectus have also shown to enhance the salivary gland function through apoptotic regulation, and other studies also show that they have been used medicinal compounds to target xerostomia. But what is different in our study is that this is the first study where we targeted directly the root cause, that is the aquaporin protein. So none of the previous studies have targeted, tried to target this aquaporin 5 molecule. Now that we know that this is the major culprit behind causing xerostomia, so using our computational method and confirming those computational results, we were able to validate our results. And one more novelty lies in that we integrated RT-PCR and ELISA. So it is like the study is proven, all together combined with computational and the protein expression all gave us the same results, that the compounds obtained from Bommeria nivea promise to be a treatment for xerostomia. So my limitation of this study would be we did till the in vitro part. So next is trying it in the in vivo, that is animal study. So future scope is that we can utilize these compounds by manufacturing oral gels, biogels, and also we can compare it with other phytochemicals so that it produces synergistic effect and overall increase the treatment outcome of the patient. And I would like to conclude by saying, despite the word xerostomia, it often means as a minor inconvenience, it significantly alters taste, and overall the quality of life of the patient is very much affected. So, thank you, sir.
Okay, nice presentation. So I have a few questions. Actually, you said you have used epithelial cells, like it's a normal cell lines, right?
Yes, sir.
So what about the biocompatibility or toxicity testing towards that cell lines? Have you performed that thing?
No, sir. Toxicity
So
test.
without that, how come you will come arrived into a specific concentration? So
Like
you have
we
used a series of concentration, right? How you arrived this?
like we compared it with the control, sir, DMSO. So based on that concentration, we
No, have you used any control drug for this? Because you have used the
pilocarpine,
phytochem.
sir.
Pilocarpine.
Pilocarpine.
Okay.
It showed more
And
effective.
DMSO, you said you compared with the control. What concentration of DMSO you have used?
Sir?
DMSO concentration.
One, sir. Like the same concentration
No,
as the.
actually, if you are going for a series of dilution, the concentration of the DMSO is getting reduced.
Sir, actually, like we want we wanted to increase the concentration, sir, gradually. Like
Concentration
one,
of what? You are,
like the compounds,
yeah.
and we are checking whether the aquaporin, the target molecule, is being expressed. The ultimate goal is that we want the expression of aquaporin to be more, so that it.
Yeah, that's fine. What my question is, for example, you have used three different concentration of your compound. Whether you have used same concentration of DMSO in all the three, or you have serially diluted.
No, sir.
Use the same concentration.
Yes, sir. Like one.
Okay. So have you performed Western blot?
Yes, sir.
So can you show the results?
Western. Sir, only the graph we were able to.
So, but this is ELISA and PCR, right?
We that expression I did not get the image, sir.
Okay. Okay.
Okay, sir. Okay, thank you, sir.
All the best.
Thank you, Dr. Rihanna. Next up, we have our next presenter, Dr. Divyash.
இங்க சர்ச் பண்ணு
இங்க இருக்கு கான்ஃபரன்ஸ் பிபிடி
நெக்ஸ்ட் இது வந்துரும் அப்படியே
ஓகே
A very good afternoon to one all present here. So as we all know, oral squamous cell carcinoma is one of the most common head and neck malignancy which we encounter in a daily clinical and diagnostic practice. But one question which you often tend to overlook is that, does this oral cancer biology behave in a similar way with all the tissue backgrounds? So with this introduction, I would like to present my title on When Fibrosis Alters the Oral Cancer Biology, Decoding the Immune Shift Through a Comparative Analysis of CD68 and CD163 ratio in Oral Squamous Cell Carcinoma and OSMF associated OSCC. So these are the contents of my presentation. So moving on to introduction. So according to the recent reports of Globocon 2022, OSCC is regarded as the 7th most common cancer worldwide with high morbidity mortality, and it is being prevalent as third cancer in India. Despite its advances in diagnosis and treatment modalities, this cancer is more prevalent because the tumor microenvironment is influenced by many factors like the stromal cells, immune cells, and the signaling molecules. So recently there is a paradigm shift in our population, basically. So there is a subset of this disease entity which is termed as OSMF associated OSCC, which is biologically distinct because the key pathway for this entity is the TGF beta dominance that basically promotes the cancer stemness and chemoresistance, in turn which is difficult for the treatment protocol. So now let's see about the macrophage profiling about the tumor macrophages. The tumor-associated macrophages principally comprises of two things, that is M1 macrophages and M2. M1 is anti-tumor, whereas M2 is pro-tumorogenic. And M1 usually presents, it will suppress the tumor, and it has cytokines like interleukin 12, TNF alpha. Whereas M2 macrophages, they promote the tumor. So it shouldn't be present at the tumor microenvironment because it is tumor promoting. And the cytokines which presented with this M2 macrophages are interleukin 2, TGF beta, and vascular endothelial growth factor. These all promote the invasion of the tumor, so in turn it has a poor prognosis. So now let's see about the comparative macrophage profiling in the two entities which I'm going to compare in my study. So the first, moving on to that, is the conventional OSCC, and the second entity is OSMF-associated OSCC. So in conventional oral squamous cell carcinoma, there will be an abundant infiltration of most of the immune cells, mostly the macrophages, which comprises about 30 to 50% of the immune cells, and mostly at the tumor level, microenvironment level, it will be of M2 polarized macrophages. So it will be present at the tumor invasive front. Whereas when we compare that to the OSMF-associated OSCC, the number of infiltration of this immune cells is comparatively less. That is, it comprises of up to 10 to 25%, and there is a balance between M1 and M2 macrophages. So this contributes to a better prognosis when compared to the conventional OSCC. Currently in the literature, there have been many studies which regarding with respect to the oral submucous fibrosis. In spite of all those, the tumor macrophagic profile of this entity is really underexplored. So that will be the aim of my study. So to evaluate and compare the immunohistochemical expression of CD68 and CD163 and the ratio in both conventional oral squamous cell carcinoma and the oral submucous fibrosis associated with OSCC to understand the tumor behavior and the prognostic significance in the patients. Moving on to materials and methods. This is a cross-sectional study design. So my study period was conducted between 2020 to 2025. With the approval from the ethical committee. So we've categorized into two groups. Group 1 comprised of conventional OSCC up to 20 cases, and group 2 comprised of OSMF-associated OSCC with 14 cases. So my inclusion criteria will be only histopathologically confirmed cases of oral squamous cell carcinoma as well as OSMF-associated OSCC were included in my study. And exclusion criteria, it actually excluded other OPMDs like oral potentially malignant disorders like lichen planus. Everything was excluded, and the tissue which were in proper condition were excluded since we had performed IHC for the study. So we have excluded those categories. So moving on to the parameters assessed, my study was a clinical pathological correlation. So we have assessed both the clinical as well as the pathological correlation. So we have assessed clinical features, the demographic details, habit history, and comorbidities. Because in OSMF-associated OSCC, habit is the main culprit there. So we wanted to assess what was the difference between the two entities, as well as histopathological parameters, tumor grading, anti-NM staging, and the immunohistochemical profiling. So since we have performed immunohistochemical analysis for this study, the scoring methodology was according to Klein et al., which was proposed in 2001, and the immunoreactivity score was calculated as percentage positivity into the number of positive cells. So first, at the low magnification, we have selected a hotspot at 10x, and at the high power magnification, we have selected 3 different hotspots which has the most positive cells. So from that, we have calculated the mean of it. So this is how, this was a reference table which was proposed by Klein et al. In 2001. With this reference, we have taken and calculated the immunohistochemical analysis profiling, and we have calculated the ratio for both the entities. So descriptive statistics and independent t-test was applied for the both. So this is the H&E images of conventional OSCC. As we can see, the strands and cords, and there's a break in the epithelium. Moving on to OSMF-associated OSCC, apart from this malignant epithelial cells which is being seen in the connective tissue, there is also dense fibrotic band which is characteristic to this lesion. So moving on to the immunohistochemical images of conventional OSCC. From this, what I concluded was that in conventional OSCC, both CD68 and CD163, CD68 is a pan-macrophage marker, whereas CD163 is M2 marker. It specifically only takes positive cells which has M2 macrophage. So in conventional OSCC group, both CD68 as well as CD163 was higher compared to the OSMF associated OACC. In literature, they have stated that when CD163 is higher, it leads to a poorer prognosis. So it actually compiles with the literature that in conventional OACC, CD163 marker was relatively high, so it had a poor prognosis when compared to the other entity. So this is the immunohistochemical analysis of OSMF associated OACC. So in this we can see that both CD68 as well as CD163 was comparatively lesser when compared to the cancer patients. So this ultimately had a better prognosis when compared to the conventional OACC. So moving on to the results. We have taken a comparison for both the entities, that is conventional OACC as well as OSMF induced OACC. So in conventional OACC, the histopathological profile was almost, as we all know, that they had the skeletal muscle invasion, the tumor thickness was more. For moderately differentiated as well as well differentiated, comparison was done, but well differentiated squamous cell carcinoma has a better prognosis. So in group 2, the association of habit as well as comorbidities in OSMF associated OACC concluded that there was a male predilection, and the habit history concluded that the palm chewing was the most common habit which was associated with this condition, and the site of prevalence was buccal mucosa. The laterality of the lesion was right side, and in all these patients, pain was present. Basically, the radiating pain was present with all the patients, and mouth deviation was also present. In all these patients, the degree of the deviation for the mouth was relatively higher, that is moderately higher in all of these patients, and the presence of dysplasia was severe in most of the patients. So moving on to the grading of OSMF, most of the people who presented with OSMF with the background of OSCC had advanced oral submucous fibrosis. They had reduced mouth opening and dense fibrotic bands in the buccal mucosa. And since they also had malignancy with the background of it, so they also presented with well-differentiated squamous cell carcinoma. 20% of the people also presented with verrucous lesion. So this is the histopathological presentation of OSMF associated OACC. From this we can see that the skeletal muscle invasion is comparatively lesser when compared to the conventional malignancy. So these group had a better prognosis. So this was the main profile for my study, since my study aim was to conduct an immunohistochemical analysis. So this summarizes the study of mine. So we can see that in both the groups, the CD68 as well as CD163 marker, the number of percentage of positive cells as well as the intensity of staining was comparatively higher for oral squamous cell carcinoma when compared to the oral submucous fibrosis, which indirectly concluded that patients with OACC had a poor prognosis because of this reason. So moving on to discussion. My study findings were similar to the study findings which is present in the literature. So according to Irfan et al., he terminated that increased tumor-associated macrophages was correlated with tumor size. And according to Mukherjee et al., he also told that M2 macrophages promotes tumor spread. In my study, it was also noted that CD160, that is a tumor M2 macrophages, was more in case of conventional OACC. So it was consistent with the literature findings. So I would like to conclude my presentation by saying that OSMF-associated OACC demonstrates reduced tumor-associated macrophage infiltration with lower M2, that is CD163 macrophage expression, which indicates a distinct tumor biology when compared to the conventional OACC. So this immune alteration will reflect the immunosuppressive tumor microenvironment, which will influence the tumor behavior as well as the progression. Moving on to the limitations, my sample size was comparatively less. So I would like to, the future scope of this study will be conducting a multicentric study to cope up with the sample size. So the take-home message will be OSMF-associated OACC is a biologically distinct entity when compared to the conventional OACC, because since it is being modulated by fibrosis, so it will have a less immunosuppressive effect or the microenvironment when compared to oral submucous fibrosis. Thank you. So these are my references. Thank you.
Yeah, nice work. So have you tried with different, here you are using immunohistochemistry only, right?
Yes, sir.
Have you tried with immunofluorescence or Western blotting to identify the markers?
No, sir. We have done only the immunohistochemical analysis.
So do you have any other plan to explore?
Yes, sir. In future, maybe we would like to incorporate all these factors, since
Okay. So, according to you, the OSMF based
Had a better
OSCC
prognosis when compared to OSCC at the tumor microenvironment level, sir. So it goes well with the literature presentation, which is already done.
So totally, you have used only 20.
Cancer patients and the 14 patients who had fibrosis along with cancer.
Is it fresh tissue or it's already stored one?
It's a stored one, paraffin embedded tissue. So we have collected the tissue already from the patient. So we have
Is there any significant differences between like is fresh tissues and stored one? Have you checked?
Usually we perform immunohistochemical analysis only in the paraffin embedded tissue, sir.
So that is also some period of storage is there, no?
Yes,
That's
sir.
what I'm asking.
No, sir. We actually taken tissues from 2020 to 2025. So nothing had a major difference apart from the. They all presented with the same findings, sir. So there wasn't a much difference on the presentation at the.
So there is no significance.
Uh,
Significant difference.
Differences, sir.
Okay.
Okay. Thank you.
Thank you, Dr. Divyashri. So next we have Navni.
Good afternoon, sir. The topic for my study is prevalence of lichen planus and malignancy transformation in an hospital outpatient department. The aim of the study is to determine the prevalence of lichen planus among patients attending the hospital OPD and evaluate the rate of malignant transformation with emphasizing on identifying high-risk clinical variants and contributing demographic and clinical factors. So lichen planus is a chronic inflammatory disorder which affects skin and mucous membranes. Oral forms are potentially malignant, especially erosive and atrophic forms. It has autoimmune origin which triggers like stress, medications and hepatitis C. It commonly involves buccal mucosa, tongue, gingiva and appearing in multiple clinical forms. The histopathology shows hyperkeratosis, civet bodies and ball-like lymphocyte infiltrate. The diagnosis is confirmed by clinical biopsy, sometimes direct immunofluorescence. The management includes topical corticosteroids, immunosuppressants and regular monitoring due to risk of malignant transformation rate. The materials and methods. This is the retrospective study of lichen planus cases in the year 2021, which has been taken from DIAS and examined the follow-up data to assess the malignant transformation of lichen planus. The sample size was 20. The inclusion criteria was histopathologically confirmed and diagnosed cases of oral lichen planus cases. The data collection included age, onset, treatment, follow-up, malignant transformation and other systemic diseases if present. My results conclude that the age distribution in 20 patients, the mean age of cohort was 43.65 plus minus 10.41 age. The gender distribution was balanced with 11 females and 9 males. A histogram depicts the age distribution showing a unimodal pattern centered around the fourth decade of life. As we can see in this graph, in this histogram, sir, females have more onset than males. The treatment modalities and distribution include the commonly administered treatment with corticosteroids, which is 25%, followed by antifungal agents, immunomodulators, antihistamines. A total of unique 18 treatment patterns were observed, including combination regimens. Mostly the corticosteroids were used in 5 cases along with antifungal agents, immunomodulators, antihistamines. We can see combination therapies and others are having the frequency of 6. The malignant transformation and risk profile depicts that out of 20 patients, only 19, which is 95%, shows no sign of malignancy transformation. Only a single case had unclear annotation and was treated as missing. No statistically significant association was found between gender and malignancy transformation. The chi-square test depicts gender versus malignancy, the static p-value of 1, along with commodities like malignancy, static p-value was 1, which is non-significant. Similarly, the common conditions such as diabetes and hypertension did not influence the transformation status, while in our study we found the most reported comorbidities were diabetes, hypertension, and coronary artery disease. The discussion includes the malignancy transformation and risk profile. Out of 20 patients, only 19 showed no signs of malignancy transformation. Only a single case had unclear annotation and was treated as missing. My references are here, sir. The future scope includes a larger sample size, and it's only a one single center study design. No assessment of psychological factors like stress, anxiety, triggers for oral potentially malignant lesions was not quantitatively assessed. Future scopes include the large multi-center study, and rigorous follow-up is required for assessing the malignancy transformation rate of lichen planus and help the patient. It's also necessary to note this topic as we can advise patients for regular long-term follow-ups. Along with, we can reduce the potential risk of OSCC and clinical evidence. Along with that, if any non-symptomatic lesion occurs, we can refer the patient for biopsy.
Okay, so what are the treatment regimen for lichen planus? Which one is more effective, the combinational thing or corticosteroids alone?
Combination things, sir.
Combinations. What are the combinations you are commonly using for this?
So the corticosteroids along with the vitamin C, antifungal.
So what are the antifungal agents?
Nystatin.
Okay, all the best.
Thank you, sir.
Thank you, Navni. Our next presenter, Dr. Rami Reddy Himani.
Good afternoon, everyone. So, my topic is integrating in vitro and in silico evaluation of the anti-cancer potential of Catharanthus roseus against human KB oral carcinoma cells. So, we will break the topic into how do we say first we are taking Catharanthus roseus plant and we are seeing against human KB oral carcinoma cells using in vitro and in silico evaluation of the anti-cancer properties in human KB oral carcinoma cells. So human KB cells are there; they are derived from epidermal cells. So we can say that from leaf to ligand, Catharanthus roseus bridges ethnomedicine and precise oncology. So nature remains one of the most powerful of anti-cancer agents, and integrating experimental and in silico approaches allow us to translate traditional knowledge into modern therapeutic evidence. So oral cancer is the most commonly occurring cancers worldwide. OSCC is a major health concern in Indian subcontinent. So it is a more like in top 3 most prevalent cancers in the region. So anti-cancer, what are the properties of anti-cancer? It include cell cycle arrest, apoptosis induction, angiogenesis, and ROS generation. So Catharanthus roseus, it is called as Madagascar periwinkle. Main components of Catharanthus roseus are vincristine and vinbastin, which already have proven the studies in like anti-cancer cells. So it like alkaloids are emerging components like isovithin. So LRP8 for in silico study I have chosen LRP8, which is a member of low density lipoprotein receptor family, which help in cell signaling, survival and migration process. What is LRP8? It is an overexpression and ApoE-renin binding mechanism of PI3K and AKT and MAPK activation, which enhances OSCC proliferation, invasion and EMT and therapy resistance. So aim of the study is to evaluate the cytotoxic and antioxidant activities of Catharanthus roseus leaf extract against KB oral carcinoma cells to investigate molecular interactions of its key phytochemicals using in silico docking. So materials and methods, plant extract was taken. Protocol, it is 1 mg per ml plant extract in methanol and 100 mg powder plus 1 ml solvent. It was done and mixed, centrifuge, filter, and it was stored in fridge. Next, we saw the antioxidant activity of a plant, that is DPPH assay was done, and extract was taken in 25, 50, 75, 100 and 200 mg per ml. 1 ml extract plus 1 ml DPPH. It was incubated for 30 minutes in dark room temperature and it was measured at 570 nanometer using UV visible. We calculated in percentage inhibition IC50. Then in vitro analysis was done using cell viability assay. Cell culture was done using KB cell lines. It was incubated using COT incubator, and then MTT assay was done using seed cells 1 into 10 power 4 well, which was incubated with extract and add MTT reagent. It was dissolved in DMSO and measured at 590 nanometer. Then for in silico, I have taken from IMPP80 the plant component and searched in a protein data bank using PubChem, and then using for docking I have used HDoc server, and I have checked the toxic using Tox Pro 3. Then results, if you see for in vitro analysis, the first graph represents the dose-dependent cytotoxic effect on KB cell lines. And then down figure indicates different concentrations, like different μg per ml, the different structures were seen in different concentrations. In 100 mg, it was healthy and densely packed and intact. And early signs of stress was seen and slight rounding and reduced confluence. In highest dose, we can see cells were shrunken, and to confirm it was using cytotoxic nature. All experiments were performed using mean standard deviation, and it was statistically significant values. And if you see for in silico results, it was mostly in chromogenic acid. The highest was in chromogenic acid. Then discussion, if you see, the study will confirm Catharanthus roseus extract, which exhibits potential cytotoxic effects on KB oral cancer cell lines. So results using previous studies, Catharanthus roseus, and support developing novel plant-based anti-cancer therapies, which will use to isolate individual cytochemicals. And according to previous studies, anti-cancer potent Catharanthus roseus mechanism, microtubule destabilization, ROS generation, mitochondrial dysfunction, and apoptosis index. Limitation study did not isolate individual alkalides, no flow cytometry, molecular pathway analysis, and no in vivo study. Only we concentrated on only in vitro in silico analysis, and only for in silico I have taken LRP8. So that was one of the limitation. Future scope is to isolate more components than doing gene expression studies, then combinational therapy studies, and doing nanoparticle based drug delivery system, which will benefit patient, like giving drug delivery some drugs for patient with the oral squamous cell carcinoma, which will benefit patients like gel or any form. Then conclusion. Catharanthus roseus was a promising source of nature multi-target phytochemicals for developing safer and more effective adjuvant therapies for oral cancer management. So when biology meets computational, discovery becomes evidence. Take-home message, it's like same promising anti-cancer potential against human KB oral carcinoma cells, evident both for in vitro cytotoxic and in silico molecular docking studies. Thank you.
Yeah, so your main objective is find out the anti-cancer efficacy, right?
Yes.
So you have choose methanolic extract.
Yes, sir, methanolic
So how you prepared that extract? You are directly using the methanolic extract, or you concentrated and you have to redistribute?
Sir, like after I have taken the plant, I have dried, sir. After drying, I have put, I have taken the methanol and I have did the extract.
Okay, you used a normal maceration, or what techniques you used to extract the phytochemicals?
Phytochemicals, sir, that I have just seen in silico, sir, whether it will work or not. After that,
Is there any specific reason for choosing that target?
LRPA.
LRPA.
Sir, because in both of the components like Catharanthus roseus and LRP8, they have used in other cancer types like
Yeah, but
breast.
that's fine. But is it found in KB cells?
KB cells, no.
So because when you are choosing a cancer cells,
yes, sir,
and a target, like if you are combining both in silico and in vitro, you have to choose in a way that that particular target should be there in the cell line. What you have chosen?
Sir, it was there in other cancers.
That's right. That's what I'm telling. So if you, for example, it is found in other oral squamous cells carcinoma, means you can go with that cells.
Yes.
Then only it is helpful for you to link.
Okay.
And one more thing, can you go to the results, that image?
This.
Okay. Do you think that this is the KB cells?
Yes, sir.
Have you performed by your own, or are you given to some labs?
Like when they were doing, I was there, sir, in lab.
Actually, it is HeLa cell lines. Because whatever KB cell lines you are getting from NCCS, it has HeLa contamination. So while subculturing, anyway the traces of HeLa cell lines should be there.
Yes.
So we have to choose the cells in such a way that when the KB cell is more confirmed. But here whatever the spindle morphology we found is HeLa cell line, not the KB cell line. So before like publishing this, you should be very careful.
Yes.
Okay.
Thank you, sir.
All the best.
Thank you, Dr. Himani. Next, we have Dr. Namira.
That one, no? Okay. Yeah, sure. No. Integrative vitro.
Good afternoon, sir. Good afternoon to one and all present here. So today my topic of presentation is debunking the efficacy of AI chatbots in clinical diagnosis of buccal lesion. So in today's digital era, artificial intelligence has become a part of everyday life. Millions of people now use AI such as ChatGPT, Gemini or Meta, not only for the education purpose, but before going to the doctor, they first Google their symptoms, they see what it is, and then they go to the doctor. So this shift is especially concerning in oral health, where lesions of the buccal mucosa can range from a simple inflammatory condition to a life-threatening cancer condition. Because these tools are easily available and it is available for everybody to use it, and it is very easy, fast, and so the public is beginning to trust them. So we evaluated on patient's perspective, like so the aim of my study was to evaluate and compare the diagnostic accuracy of ChatGPT, Gemini and Meta AI in buccal mucosal lesion for diagnosing using clinical diagnosis and histopathology as a gold standard, and to assess if AI platform can reliably assist patients for preliminary diagnosis of the lesions. So coming to the materials and method, so we have taken totally 90 cases, and they were divided into benign lesions, potentially malignant lesions and the malignant lesions, and we had 3 different groups. One was only images, one was only the history, one combination of history and the image. So these were the prompts given to the AI, ChatGPT, Gemini and Meta. We told, like, we gave a prompt in such a way that we get only one individual answer, which is most, which will be most most probable diagnosis what it thinks. So, and then these were the statistical analysis done. We have done Cohen's Kappa and McNemer's test, ANOVA chi-square test and ROC curve. Coming to the results, these were few of the images which we included. So in that descriptive statistics, we got, we had around 28 malignant lesions, 19 OPMDs and 43 benign lesions. So we found that when we just give an image to an AI, it started asking questions like, I can see teeth, I can see other part of the mucosa and everything. But we instructed the AI to give just one diagnosis. We need one diagnosis. By seeing this lesion, what do you think? Like that, we had asked the prompts. So we found Meta showed the highest overall accuracy compared to all these 3. In all the 3 categories. Only clinical data also Meta gave the highest accuracy. Image also Meta was the highest. While combining both, the accuracy increased. Then when it was compared between benign lesions and malignant lesion, at that time obviously clinician outperformed Meta. But there was not much difference between the Meta and the clinicians, but it had almost showed 91% of sensitivity and specificity of 85%. Then when comparison of the diagnostic accuracy across AI platform, obviously I have already told Meta showed the highest accuracy. When lesion specific was concerned, malignant lesion, like when we had put one image of oral squamous cell carcinoma, immediately Meta had given for all the lesions, it gave it as oral squamous cell carcinoma, over squamous cell carcinoma, like that. Potentially malignant lesions, 78%. And benign lesion was 83% accurate. All the lesions were showed significant, statistically significant differences in the platform performed. These were the responses. You can see how we got the responses. So my key results were Meta showed the highest diagnostic accuracy of almost 80%, followed by ChatGPT, and Gemini performed very poorly. Then when image as well as the symptom both were given in symptoms were also in patient's word, like I have pain, I have this, like that. In patient's word only we used. At that time also almost all the AI had performed well. Obviously clinician outperformed all the AI system, showed the highest accuracy and agreement with the histopathology. So coming to the discussion, diagnostic variability across AI platform may be due to the lack of oral pathology specific training. So we need a model specifically trained for oral lesions. But till now there is no particular software which is diagnosing oral lesions just by the clinical image. I'm not talking about histopathology, only about the clinical image. So Gemini underperformed in image only inputs and misclassifications. Example, ChatGPT was confusing lichen planus with leukoplakia. That can also happen in a clinical situation, which suggests AI relies on a text pattern recognition rather than a clinical reasoning. So compared to existing literature, there were few studies in oral mucosal lesion. So our study fills this gap by providing comparative analysis specifically in oral pathology. So limitations of my study where it focused only on the buccal mucosal lesion. We did not check any other lesion, and other oral side we could have checked. In future study we might check for the other oral lesions. And real world scenario, it varies, like different patient will have different type of presentation of each lesion, so we cannot properly rely on that. And larger and multi-setting studies are required, and a model specifically for oral mucosal lesion we can create in future to overcome this limitations. So my conclusion will be Meta had demonstrated comparatively higher diagnostic accuracy, particularly in the malignant lesion. But none of the AI chatbot consistently match clinician or histopathological accuracies. AI chatbot may be offer preliminary diagnostic assistance, but it cannot replace a clinician or a histopathological diagnosis. So these all were my references, and thank you.
Yeah, it's a nice try. Actually, my question is, you have used 3 different chatbots, right?
Yes, sir.
So all are premium version or free version?
Free version, sir.
Yeah. So if you use the premium version, we will get little more accurate results. And have you actually you told that when compared to the clinical clinicians, the results is a little variable, right?
Yes,
So
sir,
have you
very.
performed the clinical investigation with the same data?
Yes, sir. We first had a confirmed from a oral medicine specialist. We had the confirmed diagnosis. Then we
So you are
compared
compare
with
with
the
that.
yes, sir.
So do you have any idea? So what are the necessary suggestion to optimize in the
Sir,
a
first
chatbot?
thing is we should educate the public that you should not like just randomly upload a picture and ask like that. That will be the first thing, and then we have to develop a model specifically and with the clinician's assistant only that AI should be used. Directly we cannot.
No, actually, you mentioned one thing the symptoms or any clinical pathology, everything is varies people to people, the person
Yeah,
to person.
yeah.
Then how will you generalize that thing?
So, a few things will be common, sir.
Yeah.
Like for SCC, you can say there will be a proliferative growth or some like that, sir. But a few things like some people will have a patch in their mouth, but they will not have any symptoms. They will just have little burning sensation. So in few conditions, we can say that's why I think Meta
That's what
is
I'm
also.
asking. How this one is used in the case of diagnostics? How this
That's what,
chatbots?
sir. I'm saying that you should not use AI only to get the diagnosis.
Okay, ma'am. Good.
Thank you.
All the best.
Thank you, Dr. Namira. Next, we have Dr. Pravalika, the final presentation of the offline sessions.
Good afternoon, respected judges and esteemed chairpersons, and good afternoon, one and all present here. I am Dr. Pravalika Kakada, postgraduate in Saveetha Dental College, and today my presentation is on from pixels to diagnosis, role of AI in histopathological evaluation of dermatopathological diseases. We are living in an era where artificial intelligence is woven into our daily routine every minute. Millions of people worldwide interact with AI-powered technologies, from personalized recommendations on streaming platforms to voice assistants. Recent estimates suggest that over 5 billion people use AI-driven applications daily, making it one of the most ubiquitous technologies of our time. While we routinely use AI for navigation, communication, and entertainment, its potential in healthcare, especially in medical diagnostic, is still empowering and evolving. Importantly, healthcare delivery should extend beyond urban hospitals to our rural and underserved regions where access to trained specialists and diagnostic infrastructure remains limited. This is where AI can make a profound difference, empowering clinicians with a tool that enhances diagnostic accuracy and reduces turnover time and bridges gap in healthcare infrastructures. So today my study specifically focuses on dermatopathological diseases and in oral cavity, which manifests as various lesions, ulcers and discolorations, which we can see. And timely diagnosis management are crucial to prevent complications such as scarring, dysphagia and impaired oral functions. Early intervention guided by AI diagnostic aids in clinical and cytopathological and histopathological diagnosis. Why we have chosen artificial intelligence in dermatopathology? So artificial intelligence, particularly deep learning, has ability to analyze complex visual patterns beyond human perception. In dermatopathology, AI can assist in recognizing subtle architectural and cytopathological changes, clinical images and cytological smears, and histopathological sections. This ability makes AI especially valuable in conditions with heterogeneous morphology and overlapping histopathological features. So to approach this study systematically, first we have gone with a systematic review of an existing literature where we have found initially there are 198 articles in the database, but most of the studies were on oral squamous cell carcinoma or other carcinomas. So when we have refined it and filtered, finally we have concluded with the 7 studies which were with the characteristic table were presented there. And in that also the specificity of it was very low. So next, based on the, after identifying the knowledge gaps and determining the feasibility and model architectures relevant to the oral mucocutaneous diseases, then we have moved on to the clinical level where representative clinical images dataset was formed, and then this was evaluated. First we have done a pre-processing, then we have taken the feature extraction and image enhancement was done, and then we have done an accuracy EPCOS and ROC curve. Then we have moved on to histopathological imaging. So first we have taken, this study is a retrospective observational study. Here we have taken 1500 medical images and of distalized histopathological images, and we have made a trained data set. Each image was cropped into 224 into 224 into 3 pixels, and each data set was curated into 60:20:20. So 60 set was given for the training, and 20% of the set was given for validation, and 20% was given for testing. So after that we have curated the result. In that, the red curve we can see the area under curve of 0.96. And this side, we can see in the second graph, we can see the red line determines the training loss and the blue line determines the validation loss. So when we have graphed it, and this is the true positive, true negative, false positive and false negative table. And the second graph determines the loss and EPCOS curve. Here also the red line determines the training loss and the blue line determines the validation loss. Here we can see the initial loss was very high, but eventually as we have undergone vigorous training, the loss have been reduced significantly. So this is the final accuracies of 0.89 and misclassification is 0.1 and sensitivity of 0.990 and specificity of 0.89, precision of 0.89 and NVP and F1 score of 0.9 we have achieved. So discussion of the results. The model achieved an overall 89% indicating reliable classification performance. High sensitivity reflects the model effectiveness in correctly identifying true disease cases, while speciality indicates accurate exclusion of non-disease cases. The balanced F1 score further confirms that the model maintains equilibrium between the precision and recall and make it suitable as supportive diagnostic aid rather than screening only tool. So this shows a significant dermatopathological diseases often show significant intra and inter lesional heterogeneity, making diagnostic challenging even for experienced clinicians. So AI systems can assist by rapidly processing the large image data sets and identifying reproducible patterns and reduce the inter-observer variability. However, the complexity of the tissue of morphology and dependence on the high quality annotated data set remain important consideration. So, in conclusion, we say that despite promising results, challenges persist. Variability in staining quality, sectioning thickness, and lesion presentation can affect AI performance. Additionally, integrating into routine clinic workflows requires validation, interoperability, and acceptance by clinicians. We have developed by combining the clinical and histopathological applications. We have developed an app. This is still under transition, and we are attempting to bring together the clinical and histopathological components into application interface. At this stage, this is still in a preliminary and exploratory state, which allows to assess feasibility and workflow integration, and further validation and clinical training are planned before any real-world development. So these are my references. And in conclusion, I will say that AI doesn't replace the pathologist. It's just the stethoscope never replace a doctor. It's just an adjuvant factor which can aid in and help in further diagnosing. Thank you one and all for giving me this opportunity.
Yeah, actually you have used only the dermopathological images, right?
Yes,
Is it
sir.
possible to use any like internal conditions like tumor images, whether it is possible to train the AI with that images and you can get the results?
Yes, sir. We can. We have first developed the application, sir. Like we have given the back-end matter of the AI. Then that data set was curated. We can try it with the different.
So how
diseases.
many images you have used for this one?
Sir, clinical we have used 1500 images, sir, and histopath also 1500 images we have used, sir. And each image data set we have divided into 60 is to 20 is to 20, where 60 were given as a training first initially.
So
then
you have interrelated both the clinical features as well as
yes,
this
sir.
one. Okay, ma'am. Nice.
Thank you, sir. Thank you.
Thank you, Dr. Pravalika. So with this, we come to the end of the offline sessions. I invite Dr. Ramya ma'am, Head of the Department of Oral Biology, to present. I call upon Dr. Abhilasha ma'am to felicitate the chairperson, Dr. Arul Prakash sir, Associate Professor, Department of Biochemistry. The results for the online session will be announced shortly. It will be announced in the common online portal. So the certificates will be sent through email. Thank you. Good evening to one and all present here. So we start with the prize distribution session. So I call upon Dr. Isaac onto the stage to do the prize distribution. So first we'll start with the poster presentation session 1. First prize, Dr. Ranjita. From RV Dental College. The first prize is also shared with Dr. Sangeeta Elsiri from RV Dental College. The second prize is shared between two people, Sajia Anjum from Satyabama Dental College. We ask a representative of the college to collect. It is also shared by Deepta from Satyabama Dental College. We have to give it to her. Next, we'll move on to the session 2 poster presentation. The first prize goes to Darshan HC from RV Dental College. The first prize is shared by Divya from RV Dental College. The second prize is shared between Parnita Yadav and Shreyas from RV Dental College. Dr. Shreyas from RV Dental College. Poster presentation, session 3, Dr. Samyukta Aarti from Saveetha Dental College banks the first prize. Second prize goes to Dr. Deepika Lakshmi from Saveetha Dental College. Third prize is shared between Nandini from Adi Parashakti and Amita Mohan from Saveetha Dental College. We move on to the paper presentation prizes. Session 2, the first prize goes to Dr. Preeti Rubini from Satyabama Dental College. The second prize to Dr. Shweta SR from Adipara Shakti Dental College. We request a representative to collect it. The third prize goes to Dr. Ahila SC from SRM Ramapuram. Can we have a representative to collect? Paper presentation session 3. The first prize goes to Dr. Deepa Palani Nandan from Sri Balaji Dental College. Can we have a representative? The second prize goes to Dr. Radhika Sridharan from Balaji Dental College. The third prize is shared between Dr. Kundana Durga from Saveetha Dental College and Dr. Parashakti from SRM Ramapuram. For the paper presentation session 4, the first prize goes to Dr. Divyashri from Saveetha Dental College. The second prize goes to Dr. Namira from Saveetha Dental College. The second prize is shared by Dr. Akshara Modak from Saveetha Dental College. The third prize goes to the last presentator, Dr. Pravalika from Saveetha Dental College. With this, we come to the end of the prizes distribution. I now invite Dr. Ramya ma'am to deliver the vote of thanks.
Dear participants of the International Conference of Craniofacial Pathology and Biology, we are humbled and honored to have you all, both offline and online. And we are really grateful for the support we have received in organizing this conference consecutively for the past 4 years. I'm deeply grateful to Pratibha ma'am for entrusting this work to me, and I'm happy that we were able to execute it. And of course, it's an entire teamwork. I thank all the department, all the faculty members and supporting staff of the Department of Oral Pathology and Biology. Without all of you, this wouldn't have been possible. And we know how difficult it is to get such a program happen consecutively for so many years. And the amount of work involved is massive. You should experience to believe what goes behind in organizing such programs. I'm really indebted to all the faculty members and the supporting staff, and special thanks to the postgraduate students from both the oral pathology and oral biology department. All of you did a phenomenally great job. And your voluntariness to help is something I found the degree of voluntariness has definitely improved this year. And I'm really thankful for that. And please understand, all these experiences will make you good leaders in future. So these experiences are something which you have to take it in that spirits. And I really thank all the speakers who agreed to be with us. We know the experience-wise, they're all stalwarts in their fields. We've been listening to very big deliberations from yesterday. And we're very thankful that all of them agreed to be with us. And I would just mention that the consensus meeting was beyond extraordinary, more than extraordinary. I don't have a right word to describe it. Hopefully we shape it up and make it happen. And above everything, we are deeply grateful to Dr. Isaac, who I would say the shining star of ICCB season 4. So you really made it special, because we really respect international guests. We really are deeply thankful, because it means a lot to us. And the level of expertise which you brought in and the knowledge which you shared is something I would say it was phenomenally great, because this is something what the dental fraternity needs to know, and that is what you're doing. And many things which you had mentioned, especially the trimethylamine oxide and all, were mind-blowing, and we are ready to collaborate on those areas. Very, very big areas, and I would say if all the participants had just time to just go on to search publications, you would know what dentistry has really to offer. There's a deep link between systemic diseases and dental diseases, and if you can know it strongly and confidently, all of you would be sought after in a very big way. And that is what the evidence what he's trying to create is very big. You are actually throwing open dentistry to very big areas, and we are very, very special, and that's what he's doing. So thank you so much, sir. A very apt presentation, which really elevated our conference knowledge sharing, and thank you so much. We are deeply indebted. And special thanks to Abhilasha for coordinating with Dr. Isaac and making it more special. And I can keep listing out every single name, and all the help which you have done in contributing will always be remembered and will always be grateful. So thank you so much, and thank you so much for being here. And with this, we are signing off ICCB Season 4. Thank you so much.